Okay. Thank you, everybody, for joining us on our third day in the program, third program on digital dentistry. As you know, this time we are talking about digital implant dentistry. And our first lecturer is Dr. Puya Sultanzadeh. He is a periodontist, FACP, assistant professor in School of Dentistry, Loma Linda University, California, USA. He has a private practice, and I know that he has many publications, many presentations, and so if you don't mind, Dr. Sultanzadeh, we go for the presentation. Dr. Sultanzadeh. Dr. Sultanzadeh is Master of Science in Prosthodontics, special training in Advanced Prosthodontics, postdoctoral training program in Prosthodontics, and Doctor of Dental Surgery from Tehran University of Medical Sciences. The other degrees are from Loma Linda University, California, licenses are Diplomate American Board of Prosthodontics, California Dental Science, Washington State Dental Science license, Western Regional Examining Board, National Board Dental Examination Part 2, National Board Dental Examination Part 1. And academic responsibilities of him are practice manager, Department of General Dentistry, Assistant Professor, Department of General Dentistry at Loma Linda University, faculty practice teaching for complete dental course in LLU, California, clinical teacher assistant in Zimmer Institute, California, clinical teacher assistant in removable partial denture course, UCLA, California, clinical teacher assistant in removable complete denture course, UCLA, California, and as I told, he has private practice at Puya Sultanzadeh, Anaheim Hills. So, okay, Dr. Sultanzadeh, can you share your screen with us?
Sure, sir. I got disconnected for a couple of minutes, so I had to restart my computer.
Okay, okay.
Hopefully.
Take your time, Dr. Sultanzadeh. As you know, our last lecture has canceled. And your friend is here, Dr. Sadeh, for your friends, friends.
Good morning,
all of you.
Yeah, actually, it's our time, morning. So your time probably
midnight. Honest. We can see your slides. You can make it full screen. Dr. Sultanzadeh, can you hear me? Do you hear me? به نظرم تصویرتون چیز شده فریز شده
از اون ور یا این ور؟
فکر کنم از اون بره چون خودش گفت من دیسکانکت شدم
Okay, I'm back.
Nice to have you back.
So I don't know, every time that I go full screen for my presentation, it just get an error and then it makes me restart my computer. So I may not do the full screen this time. I just like expand the window on it.
Okay.
So let's see what I can do. Oops. So then, okay, let me share. So do you see my screen pretty well,
Yeah.
right?
Yeah, completely.
Okay, so I'm not gonna like do full screen because if I do again, it may restart my computer. All right. We're good. Shall I start or we're gonna wait for a little more?
Yeah, please go forward.
All righty, so I'll try to wrap up this presentation within 30 to 45 minutes. So thank you again for inviting me and having you here, Dr. Sadipur. Hello, wa alaikum. Okay, so what I'm going to talk about today, you hear me pretty well, right? Everything good?
Doctor, everything is okay.
Okay, so I'll continue. All right. So today I'm going to talk about like a CADCAM dentures, CADCAM technology, and a little more focus on removable prostheses. However, I'm going to like show some cases on fixed complete dentures, or as we say, hybrid. Nowadays, like everything is going toward like CAD/CAM, digital design, virtual smile, all those things. And it's actually good to have an update on that. And I was like, as Mr. Hakobian just mentioned, like we had like a big convention. It's called CDA, California Dental Association. And every other booth that you go and you check their products, they're all about like AI, CAD/CAM, printing, milling, all technology. And it's very crucial to just know all different aspects of that in every single procedures in our dental world. So why we like CAD/CAM dentures while we are focusing on digital dentistry, especially in removable pros or whatever related to that, because it's possible to recall all the clinical information for complete denture almost within like 1 or 2 sessions. However, as clinicians, we never just insist on that, telling this to the patient. Sometimes it takes 3 to 4 sessions, but there are a lot of other superiority and good advantages on CAD/CAM dentures that we would like to take advantage and tell them, okay, this is like a high technology thing. And I'm going to mention all these benefits in future slides. It may take less chair time because basically in a lot of cases, we're going to do scanning, maybe some impressions would be performed, but overall like less chair time would be needed for these kind of cases. And we're going to have all the digital data, and it makes the process faster overall, like from data acquisition to processing, designing, and fabrication. And there's much less labor time and labor work involved. And basically a lot of times, like we need a clinician on the computer that computer savvy, know how to design and then communicate with the clinician. And then off of that, they go for the final fabrication of the product. And always like when we fabricate the new dentures based on patient's request, we can make exactly the same dentures that they had, or we can duplicate their previous dentures that they're worn down. Also, like we always have like a digital copy of that dentures that is being fabricated. And for instance, if they lose their dentures, if their dogs chew on dentures, if they break it or anything happens to it, we can just simply call the company, they have the records, and request to to refabricate for us, and it would be in our hands maybe within a week or maximum two, the final products. So these are really great things to have as a kind of like a CAD/CAM denture. On the other hand, all these studies are talking about like we have a very superior denture base fit because everything is pre-polymerized, and majority of like a good CAD/CAM dentures that we have in the market, they are milled. There are a lot of studies comparing the 3D printed versus milled dentures, and they all say still like milled one, they're stronger, they're more plaque resistant, and they have a good adaptation. In some certain areas, printing might be better, but it's still printing technology is not there yet to say, okay, let's use printing dentures over milling. Still milling is superior to printing. Also, like studies again show that they are more dense, they get less Candida albicans, they get less a residual monomer that in some patients may create an allergy or some tissue reactions. And also this process can be combined with like conventional or digital, and it can work hand in hand. And sometimes we can easily just scan the dentures and switch it over to digital dentures. I've done it before that the patient loved her dentures and she requested just have a duplicate. I simply scan with my intraoral scanner, not a desktop or lab scanner. I simply scan them and send it to the company, told them the shade, and they refabricated us like a duplicate. So the patient always had a kind of backup for any kind of situations. This is a very high-cited research that done by my friend, Dr. Goodacre, and then he evaluated the denture-based fits between different types of dentures, and he found out, of course, like as you can see from these graphs, that in general CAD/CAM dentures, they have way more adaptations. If you look at like the yellow and green surfaces, the green markers, you will see that it has much better adaptation and fit over the models that he fabricated. On the other hand, when you look at some other studies that they did some systematic reviews and meta-analysis, this article is for Journal of Dentistry, published 2021, and they also found out that the overall CAD/CAM dentures, they need fewer patient appointments, they reduce the clinical time, and you can achieve a better results off of it. And also the cost would be even less down the road. And the CAD/CAM dentures, they offer a number of improved mechanical and surface properties that the conventionally processed dentures, they do not. On the other hand, it was very fascinating that talking about the cost, because like this lecture, mostly because of my experience and a lot of like research behind it, I'm talking about Avident Denture, which is the pioneer and the first company that came up with the CAD/CAM dentures. I went to the booth and I saw that they have cut their prices drastically down. So I remember like making like a denture with them. It was like over around like 1,000. Now it can be as low as 600, just the lab fee though. And this is kind of reasonable for a kind of denture. And for the hybrid prosthesis, which is like the fixed dentures over the implants, they used to charge 6,000, 7,000, and now they're conventional one, regular one with the bar, which I'm going to explain later on in future slides. It's come down to 2,500, less than 3,000, which is the normal labs. They also charge us the same amount of fee, even maybe a little more. They usually charge around 4,000 to 5,000, and then this company has brought it down to $2,000 to $3,000. So it's a very good incentive as a clinician to have a better outcome, better results, and even like have a little better profit on these kind of cases. On the other hand, like this is a study done in Buffalo, New York, and they evaluated the surface that coated with Candida albicans, and they saw like the conventionally processed, they have 8% of the surface covered with the albicans versus the milled one, which is 2.2%, and for Avident denture is 0%. So this is really important because a lot of people, if you see that they're wearing dentures for a long time, the dentures smell, especially if the oral hygiene is not the best. So you can appreciate like the smell and the odor coming from the dentures. And in many cases, we recommend to replace them or soak them every night into solutions, all those things. And this is like a very good and great advantage and improvement. Also, when you're talking about the denture wear and the wear resistance, also this study shows that the Avident dentures, they have very similar wear resistance to Dentsply IPN, which is a really good and resistant denture teeth. And from that matter, also like they looked at it and it has superiority or like at least like comparable to the conventional denture teeth. Disadvantages, it could be mentioned as, first of all the clinicians, they need to be trained. It looks like a whole new era of dentistry. You know, you need to know the procedures, you need to do troubleshooting. It can be expensive sometimes. It depends on the steps. And also, as many people, they advertise about the two appointment protocol, which is basically not that much true. It can be up to 2, 3, 4, sometimes 5 appointments just conventionally. But I always just tell the patient, it's not about the appointment, it's about the quality. It can be expensive, still is a little more expensive than conventionally processed. However, in hybrid, as I mentioned, it seems like less expensive. And of course, it's not available everywhere. I don't know about Iran if it's available or not, but in some other countries it's not. And in US,
I don't think it is available here. I don't think it is available here. Provident or something like that. I don't think it is available.
Any kind of companies that do the milling dentures, they're not available here. They're in Iran.
Not yet, maybe, hopefully.
In the
future.
next future, near future, yeah.
Hopefully. Well, because basically right now there are a lot of unknown companies, like their names are not very famous, but a lot of companies and local labs here in the US, actually what they do, they get the POC, the Lucitone POC or the pink porcelain, the pink PMMA POC, and they design and they mill their base, and then they have the inventory, the module of the teeth, and they individually bond the teeth over the base. So it's not that of a kind of rocket science, but it's doable. And a lot of local labs, they actually do it. It doesn't have to be a big name like Avident or Ivoclar or any other companies. They can still mill something off of that. But again, it needs a lot of like experience, training, and all those things. Right now, some of the more common commercially available companies that they make CAD-CAM dentures would be Avident, iVotion denture, which is by Ivoclar, Dentica, mostly focusing on 3D printing dentures, Pala Digital dentures, and a lot of like German companies. I've noticed that they're fabricating these things, and they're kind of like improving a lot in that matter. So we can use the CAD-CAM complete dentures or removable prostheses in different areas. And maxillary mandibular complete dentures, immediate dentures, single arch dentures. You can use it for full arch prostheses. You can use it for conversion of that, like at the day of the surgery, you just attach it to the implant. You can use it as like a permanent thing, and also like obturators. And I've done a couple of them as well. And you really get very good results off of that. They have they have two overall Evident has two systems, which one of them is like they mill the base, just like on the left picture. Unfortunately, all these things they have animations. I'm afraid if I put on full screen again, it closes on me. It would make it a little difficult. But however, I'm trying to just move around the pictures to show you. You can mill the base. They will mill the base, and they have the teeth, and then individually they bond the teeth to the base. And the other technique that they have is the base and the teeth, both of them are milled together. And if you want like a advanced, like kind of premium type of thing, there's another technician that they can come back and do some staining, glazing on that to make it more natural. But they call it XCL1 is monolithic, and the XCL2, they can do a little cutback, they can create translucency and some pretty features on that one. Really want to go to the slideshow, but so overall, like we can do the records, and after that we can digitize the record, which I'm going to talk about it. We will submit the digital treatment form, like the prescription form, basically to the lab. They will design it, you will approve it, and they do the production, and you get the final product off of that. Just like, for example, in this case that the patient had existing denture, they're worn down, the fit was not great. So, and they come to your office as first visit. So even at the first visit, you can start doing a digital denture. So basically you can make a potty index from the denture to make your immediate cast off of the denture. And then you can make your tray off of it. And if, even if you have some thermoplastic trays, they can heat up and you can mold it over that like putty cast. So you have your immediate cast, and then you do your final impression, and the result will be something like this. And then you submit this along with other records to the lab, and they will scan it and will give you the denture. The reason I'm talking about, I know that the topic of this presentation is about overdenture, but basically denture and overdenture, the same concept. Is just like you need to incorporate the digital planning for the implant into the denture. So it's good to go overview and then see everything about like these dentures. Or if the patient is okay with the denture, we can simply scan it. If it is not the best, then we can do a wash reline basically with light body PVS. We can make a liner inside the denture and put in patient's mouth and do a functional impression, and then scan the denture inside and outside all continuously. You can always use it with your intraoral scanner. Also, like especially for maxilla, you can do the direct scanning, just like what you are seeing in this picture, in this video, and they will see the anatomical line. The important thing about direct scanning of the jaw is when you are scanning it, you need to pull the cheek out to create a kind of a nice depth, to show, and we scan the nice depth of the sulcus. So in that case, as you can see here, we can see the depth of the sulcus, and based on that, the technicians in the lab can detect the margins, and they can give you a very good borders and well extended flanges. So the retention would not be compromised on that. Overall, what you need to have is you need for a set of dentures, you need the maxillary and mandibular dentures, and you can have a wax frames, maxillary mandibular wax frames, or if the patient has not lost that much of the vertical dimension, you can use the existing dentures and you can scan them, and you get a kind of vertical dimension. Or you can make those for the second session, do the wax frames, scan them, and send it to the lab, or just send the wax frames to the lab. So there are different ways to do that. And the other way that it's been done, I have not done it, is you can measure from the crest of the upper, the crest of the ridge from the lower jaw to the incisive papilla of the upper arch, and then have the average number to see what's the number, and then give them the number, and then talk to the lab technicians regarding that. But you have to make sure this is the right vertical dimension. In these cases that you're not 100% sure about the vertical dimension, it's been recommended to get the ATI or Wagner Trine. I will show you in future slide how it's going to look like. So basically, the lab, the Avident or other companies, they will make you a temporary denture, like a very quick 3D printed denture. They send it to you within 2 weeks. You put it in patient's mouth and you do the corrections and modify it, scan it, and send it back, and that will give you the final product. So I will show you these slides and everything at the end. And then toward the designing part, you will get those things, and they will make the caulk off of it, and they will bond the teeth into the recesses of the denture. And then that would be the final outcomes of the denture. And then some parts are optional. You can ask them to put Rogaine in, you can ask for customizing or shading it, and there are different options, and then you can get a really, really beautiful results off of it. This is the same patient before and after, and it's really hard to say, is it CAD-CAM or not CAD-CAM, but very similar. And you see, like, that's why I need animation. It looks like a very busy slide, but it all comes with animation. I don't know if should I try it or not. I'm afraid I just shut
You
down on
can
me.
show for this slide animation, just for this slide.
Well,
think-
as soon as I put the slide mode, it will shut on me. Let me. Okay, if it shuts off, I'll try to restart. Come back in 2 minutes. Okay.
All right.
Okay.
Let's give it a try. Hopefully nothing happens. 1, 2, 3. Oh, there you go. Good. All right. So as you see here, for example, when you have a text, you can ask them to do some options for you. They can give a textured finish and highly polished, or they can just do very smooth, clean surface for you. They can add Rogaine or not Rogaine. And what I usually do regarding the Rogaine area is, if the patient has existing denture and it does not have the Rogaine area, like the incisor papilla area and the denture, I'm not going to reproduce that. But if I'm giving the patient an immediate denture, basically the patient has already her own teeth, or his or her own teeth, which are not in good condition, I'm going to extract everything, but does not have to use the denture. So denture would be the first time experience for the patient. I will usually add the Rogaine because it helps them to feel a little better regarding the tongue, the phonetics, and speech. Also, like conventionally, we're talking about posterior balancil seal. And why we create posterior balancil seal is because in the conventionally processed denture, we have shrinkage. So one of the reasons we create that posterior balancil seal is to compensate for the shrinkage. But are we having that in milled dentures? No. So that's why, like in many cases, we don't even need to do posterior balancil seal, and it's an option. I still personally, I want them to put it in just to have a little compression, and also it avoids the food odor. So, and if you're talking about like the overdentures for maxilla, if you have 4 or more implants, we usually cut the palate off. So basically PPS doesn't have any meaning. And you can have
Dr. Puya,
yes.
may I ask a couple of questions regarding the provisional denture for the temporary phase? Since you mentioned about the cost of the denture, do the lab technician ask you for a surcharge for the temporary denture, or it's a part of the deal?
No, it's the same fee. Immediate dentures and conventional dentures, usually they have the same fee.
All right. And another question for this type of denture, since there is no need to print the PPS, as you mentioned, there is no shrinkage. So would that be an option to differentiate this type of denture rather than the conventional old-fashioned denture?
Well, this is an option. It doesn't matter. Many people, like including me, we would like to have it still on. But if you get 2 dentures, one conventionally processed and one milled or CAD-CAM, it depends. If you have seen the most, in many cases you may tell like this is like a milled denture. One of the advantages that I forgot to put in here is the milled dentures. Usually they are a little lighter and they are thinner, but also very stronger. And
Right.
patients, they feel much better about it, especially about the palate. You can request them to go with minimal like thickness on the palate, and they feel like, oh my God, it has a better fit. And the patient really appreciate it and differentiate it, like sensing wise.
May I ask a question? now that we have interrupted your lecture, may I
No
ask a
worries, it's
question?
good.
When you recording the jaw relations, how do you make it send it the data to the software? How you scan it? Do you scan inside the mouth? Do you send it to the lab to be scanned by lab scanner? And then
So I'm going to mention it in future slides. There are different ways, but basically you can also do a very conventional way, just like wax trim. You can do it with wax trim. You can scan the wax trims and also send them the wax trims, or scan the whole wax trim and scan the bite and send it to them. So they virtually they can superimpose those. But you can do anything. You can, as much as a like a clinician, you are sure that you are giving them a good bite and a good consistent CR, you can do that. And then, as I said, if you are not sure about it, you can request for a trial denture. So they give you a 3D printed teeth, like a denture teeth, off of the patient's scan, and then you will try it in, you will adjust it, and then you get the bite and you send it back to them. Or you can scan it and then send the virtual scan, because they have already the data.
thank you so much.
Yeah.
Great. And one more question, Dr. Priya. Since you mentioned about the thickness of the heat process conventional denture, how much is the minimum thickness of the milled denture? Do you have a
well,
reference for that?
it's hard to say, to be honest, but you can go as thin as 1 mil to some areas, like which is not like in the load bearing area. You can request maybe a little even thinner, but usually like 1 mil is a safe thickness, which in actual denture is usually much thicker.
All right.
Yeah. You can, in the palate area, sometimes it's literally see-through, and you can go sometimes half a mil. I just delivered 2 dentures, basically kind of a partial denture. I actually have the case toward the end, and the thickness was almost half a mil, and it was like very thin, which I was a little afraid about, like the fractures. So what I did, I just roughened it up and I thickened it up with like a cold cure resin. So just make sure the patient will not break it. I'll show you that
Right.
case actually.
All right. Thank you.
So the mill bases, it can be just like conventional way. They can mill the base, and if it's monolithic like that, they put the teeth and they mill from inside, and you can see the base of the teeth without even, they call it reverse milling. And this is what I'm talking about, customization of the denture for some special patients, they request that. So obtaining the clinical records. So this is the trial denture that I mentioned to you. So when you do the impression or scanning, they can send you something like that. And you also, this company makes some, they call it a true-fit denture, if I'm not wrong. They come in 3 sizes: small, medium, and large. And it exactly looks like this. Come back. Looks like that. And then you basically you adjust it to the patient's mouth. It looks like a tray, but it's not a tray. It's like a denture teeth. And then you do a wash reline, you do impression with it, you treat it as a kind of a tray. And then you do your bite registration, vertical dimension, everything off of that. And then you send it to them. And this is going to be how it's going to look like. And then they look at the interocclusal jar record, the space and everything. They play with it. They send you the preview, and they will fabricate you the final dentures. This is one way of making that. You can also duplicate the denture, the existing dentures, or scan it and get the bite. And what you can do, I've done it before. The patient comes to your office with like worn down dentures and lost vertical dimension. You can easily, like, you can put a leaf gauge or a little composite or maybe a wax and open up or restore the vertical dimension. Now, rather than like a collapsed bite, you have a kind of restored bite, and then scan each side. So you put, like, for example, on the left side, the wax, and now you know, like, the vertical dimension looks good to you. and you scan the right side, which has a space. Then remove that wax, and then, I mean, you do the bite at both sides, and then you scan each side without the bite. So you keep the right side, the wax, you scan the left side, and then you switch it over. You keep the bite on the left side, and then you scan the right side. And then eventually when the scanning look, how it's gonna look like, it would be two dentures opposing each other with some space, just like it's kind of a CR record. And then they remake the dentures and then fill up the space with the properly sized and normal unworn teeth. And this is how it's going to be like that eventually. And this is how the patient will look like. So if you want to go for overdentures, and if the patient has existing implants and locators, you can simply put the analogs on top of it, and you can do your...
Puya, please, there's a
Problem in
problem with your slides. It goes back and forward.
So please, I think you should stop the play. Since you
We
click
do
on
have the
the
slide for the overdenture, but it goes back and forward. I don't know
Your
your
why.
topic is implant overdenture, but it goes back to base options.
Okay, let me see. Do you see this right now? I mean,
Base options, and now implant goes back to the.
It goes to previous slides and again, implant overdentures.
okay, right now I'm gonna stop at implant overdenture.
You just see implant overdenture, but here we see the former slide.
Oh. What do you see here?
Isn't it due to that play option that you put on?
Let me just get out of it. Do you see this now?
Yeah, yeah.
Now it's solid. It
Yeah.
stays.
Okay. So I'll go there. If there's something special, then I go back to the play mode again. Okay, so for implant overdentures, more specifically, is the same rules, the same things applies. The only difference would be you can make an impression at the time from the implant position at the time of impression, or what I have done a lot of times is if the implants are not exposed and the patient has denture, I usually tell the lab, okay, these areas we're going to place implant. So we make the CADCAM denture, and then I asked him to reinforce it. They put a very thin tie mesh all around inside the denture. And then when it times to pick up those locators and put the female attachments inside the denture and the male attachments or the implants, then I just hollow out and create some room, and I pick them up intraorally. So that's the way to do. And then Avident, I just talked to them a couple of days ago. They have a new technique that they can custom 3D print titanium over the cast, over the inside the denture, and then embed it and make it a one-piece denture. So it's like more strong denture, and it's very thin. So if you want to grind it or something, it can easily, it could be done with that technique. And this is like the preview. Let me see. I'm going to play again to see if you can see it. So this is the preview that it comes. So this patient upper is immediate denture. We're planning to do that in lower, just like regular dentures, natural teeth, and they overlay the records and everything, and they superimpose, and based on the teeth position, they try to get the most perfect situation in the position anteriorly, posteriorly, buccolingually, and then they give you an immediate denture. And that's the final thing. That's the final preview.
So there's no need for taking impression with the scan bodies or conventional impressions from the implants.
No,
I
but
didn't.
you can also, if the implants are exposed and if the implants, they have already the locators on, you can submit it with the scan of those two, and they already will hollow out the final dentures for you with that in it. So they already hollow out for you. So it, again,
So it makes
it's very
everything
easy.
yeah, it makes everything very easier, so much easier.
Yeah, super easy. It's like, it's just a matter of doing few cases with them, and as a clinicians, you do that and you will love it. The only disadvantage again is the expenses, and they are trying to bring the cost down and make it more available. Because, for example, Avident, in order to be able to use Avident for your patients, they ask you to pay a membership, I think, to become an expert or something, 5,000 or 10,000, something like that. And you become their clinician, the expert in their club, and then you needed to submit certain amount of cases. Also, it was really hard to work with them. And then also the prices were higher. But now it seems like a new, I'm not sure it's a new CEO, but new marketing person and new people, they took over the business, and they're trying to make it more easy and more affordable, because they want to compete with a lot of labs and local labs. And it's a great thing to use that. Now imagine, yes.
Sorry, interrupt you. Would you stop that play option because the slides go back and forward here?
Okay.
All right, now it stops. There are two more questions came up in the chat room. Is it the proper time to ask you now?
Yeah, go ahead. Yeah, you can stop
Right.
anytime.
There was a former question regarding the Facebook. How do you manipulate the Facebook for this type of digital complete denture?
So this company, they had like a ruler that you can use a certain amount of like measurements on it. Let me see if I have a picture of it. I need to look for it. It's somewhere. I will show you. But also you send them the photos as well. And nowadays, I don't know, are you familiar? Have you heard about Rayface?
What again?
Which face?
Rayface.
No, I'm not familiar with that.
So nowadays there are a few companies, they're also making some 3D facial 3D scanners. So basically they consist of multiple cameras. Actually, I have it in my office. We can FaceTime you another time. I will show you how it works. That they have like around 10 to 12 cameras all around. It comes around the face like that. It has big wings, and it takes a picture. And what it helps is like it captures and helps all the landmarks. For example, Frankfurt line, horizontal line, and everything. And it merged that to the intraoral scan. For example, if you scan inside the mouth and you have that facial scan, and then you have a CT scan of the patient, it merged all these three data together, and they give you a rough idea. Now, regarding the Facebook, again, if you don't have that, which is this is a new thing, and I don't expect like people they have it much, but regarding Facebook, a lot of like, I know it's kind of controversial, but a lot of research also shows that especially for dentures, it's not a big deal, like not using the Facebook. And the biggest error that you may get would be like the second cusp of the second molar. And what they do, they set the teeth based on the averages, based on the normal averages, which is like I think 10 degrees and 20 degrees for the joints. And regarding the occlusal plane, they go by the pictures, and they go by some measurements. And don't forget, you're also providing them some sort of wax rim and base plate. So you basically, when you give them the base plate wax rim, you are, as a clinician, make the judgment about like the occlusal plane be parallel between the interpupillary line and all the Fox plane, G plane, all those things. As a clinician, you tell them. And then when they give you the digital preview, you again have the opportunity to review that. And also, again, another checkpoint would be if you request a 3D model, a 3D printed trial denture, they will give you. I will show you some cases how it comes out. But there are multiple ways to do that when you see it. You know what? Let me just go very quickly show that case. Okay. For example, this patient, he came and I made the digital denture, but if you look at it, the occlusal plane is off. And when you put that, it's not parallel to the interpupillary line, and it's not good, right? So what could be done is basically I added wax to that trial denture that I received from the company, and I made it right. So now it's all good. Then I send this back to the company. You can also scan it and send this scan to them because they have the previous record. And then you can do a wash impression or something. So this is what you send the actual model to them. This is the trial denture. So not only I washed impression to make sure the fit is perfect, I also added wax, I got the bite, and it's all they need. And this is how it looks like. The patient has some lip asymmetry when he smiles, like the upper left lip like lifts up a little more, but now everything is like super parallel to the interpupillary line. But this is one of the things that you can do.
All right, so this is a kind of complication we face during the trial, and you can adjust it easily. Nice.
Yes, it's super easy. This is, and then actually you can also, in order to avoid paying them, if you have 3D printer in your office, they can send you the STL file of this trial denture. You can 3D print it in your own office and then try it in patient's mouth and then send everything to them.
Great.
So, everything has become much easier.
All right, let's go back to the overdenture that you delivered the abutments. It could be ball abutment or locators, depends on the system that you choose. And you mentioned that, and you mentioned that you scanned the abutments at the time of
impression,
soft tissue scanning. So how does it work? Do you inform the system from for the implant system or brand of the system? Attachment. How do you define it?
So overall, like, I mean, the thing that is very common in the US is like locators. They are not, I mean, we have ball attachments, different type of attachments, but ball attachments nowadays, it's not used much in US actually. And a lot of them is just locators. But even if you use ball attachments or locator attachments, they have the data, and then you can also scan it, because at the end of the day, you can pick it up intraorally. So you only scan that. You can put the analog on it, or you can scan the abutments, and basically they hollow out the inside of the denture for you. And then you have the female attachment, and then when the denture comes in, you try everything good, then you pick it up intraorally, or you can just put the female attachment on top of the locator or the ball attachment, and then pick it up with impression, send it to the lab, and they will process it for you, attach it to the denture.
We have
we make a framework for the denture, for the overdenture. So since this type of digital denture, it's milled, so it's stronger than the conventional heat process denture. So there was no need for metal frameworks. Am I right?
Yeah. A lot of cases, when you talk to the companies, they say you don't need to reinforce it with metal, but it's still sometimes you need it. And then they have the technology to, and I've done it. They 3D print the metal framework, and then they incorporate that into their milled denture. So, they do everything for you.
In summary, if you want to send the to make a bar or individual attachments, do you take just a scan of the oral mucosa and send it to the lab to form the bar for you? Or you first make the bar and then scanning it for the overdenture?
Well, everything has become much easier because, for example, evidence, what they do, you can scan or do the impression and then send it to them. And this slide is actually talking about it. They can design the bar for you. They work with the third-party companies and they will mill the bar for you. And then they receive the bar and then they scan the bar and they design your denture including that bar design into their denture. And then you get the bar and you get the denture. You screw the bar into the implants and then you put the denture on top of it. So they will do that for you. You don't have to make the bar, or you can scan it, make the bar, then do the impression, and then they will refabricate it. But what I've done before is like, you can do, and then it comes for full arch scanning, different techniques like open tray, closed tray, all these kind of impressions, or full arch scanning, but you have to make sure you have some landmarks. So the stitching the points is close enough so you don't get errors in full arch scanning. And just like this picture, they will virtually design, you see here. So you just send them the cast, which is the actual impression. They will design the bar and design the tooth, and based on the design of the denture, they will design a bar, and then they accommodate everything inside that. Was it clear, like what I explained?
No, thanks. No, thanks. It was quite clear, and it seems very easy. Is it is it precise or completely, or sometimes you have to do something again?
Well, the precision of the procedure, it all comes from your accurate impression. If your impressions are accurate, then what they make will be very accurate because they have also their own standards and checkpoints. So, and the full arch scanning is a different topic, but even if you want to scan with the scan bodies, or if you want to do the impression, verification jig, all those things, if you want to make a bar, this is a totally different topic. But whenever they receive their things, it's going to be accurate because there's no casting anymore. I don't know any lab right nowadays that they do any casting. Everything is milled, and milling, there's no shrinkage, and it's pretty precise and very accurate. And I'm talking about milling the titanium.
Yeah, and compared to gold, it's cheaper and also it's lighter.
Yeah, I mean, nobody uses gold. I haven't seen anyone uses gold actually right nowadays. So a little talking about restorative space. Overall, whenever we have like locators, we would like to have around 10 to 12 millimeters of space from the implant platform to the occlusal plane. And we need that space because we need a little room for the soft tissue attachment, a little room for the metal attachment, 2 to 3 millimeters for the metal capping on it, and also minimum 2 millimeters of acrylic on top of the metal housing, and you need some room for the acrylic lead. A lot of times, it's not only also about the vertical space, you need to be mindful about the horizontal or the width of the denture too, which we need around 9 to 10 millimeters of thickness. That's why we usually do not like to put the locators or attachments too much anterior of the arch, and we would like to have it a little more toward canines or premolars. So in that case, we can have more thickness or so. And I'm going to show you a case that actually a little got difficult for me to restore it. And for the bars, which we have different type of bars, we basically need at least 14 millimeter of space, basically the same amount of room that we need for all on four, we need for the bars. And it's very like, it's such a big restorative space required. And if you want to do bar locator again, it can be even more than that. So all these restorative evaluation and data acquisition, it should be considered before even placing the implant, because when the surgeon wants to place the implant, they need to know how much restorative space required. And as a restorative dentist, you can tell them, okay, I need that much, maybe we need that much of like a bone reduction or so and they need to know, are you going for locator, are you going for the bar? And usually for maxilla, a lot of surgeons, they prefer bar, because there are more failures of implants on the maxilla versus mandible, which is, we like it more individually restored or individual locators. How we can do these measurements ahead of time? One of the things is like, you can have like a diagnostic setup, diagnostic teeth setup. You can ask the company to make you a radiographic template, or the lab makes that, and then send the patient to the CT scan with those things in. And basically, this is how it's going to look like. And then you know which design you're going to do, and then you can do your measurements visually. Now imagine a patient comes to your office with their dentures and they want more retention and they want to do some implants underneath. So what do you want to do? Either you can duplicate, but one fast way that you can do is basically you can get those like lead foils from the PA radiographs that you have in your room. You take them out and then you put it on the denture and then open up the papilla. So in that case, you have the teeth outline and you can secure it with some wax. And that's how it's going to look like eventually on the CT scan. Now, you know, for example, you have enough width and height for implant in canine area or premolar area or vice versa. So this is a very good, quick way to obtain some information, because as you know, when we do the CT scan, these denture teeth are radiolucent and may not show in the X-ray much. That's why you need to make them radio opaque. And this is another case that has been done. And you need to do 2 times a scan. I'm going to explain more. This is another way. So patient will get the CT scan with these things in their mouth. And then based on that, you can see how the designing will go. They detect the nerve. Okay, I want 2 implants in the canine area, and how you can tilt it, what thickness you want to do, and how you want the emergence profile on those things. The other technique that is very neat, I'm gonna go full screen to see if it let me do that or not, is using some markers. So the thing that is available here is called speedy markers, and they are used for skin radiology or mammograms in medical radiology. Basically, they are like a small balls, like 2x2 balls, and you can stick it to the patient's denture. And now you only need to do like stick it to the denture teeth, and you need to have 5, 6, or 7, but stagger it pretty well. And then you need to have 2 times a scan. One with these dentures outside the mouth and one inside the mouth. And we call it benchtop scanning and also intraoral scanning. And you can also use your digital intraoral scanner and scan these things, because STL file eventually is something that is good to use. So you need 2 data points, 1 data point from the bone, 1 data point from the denture, and these metal beads, these metal balls, actually, they are the mutual points that you can superimpose these 2 together, and this is how it's going to look like. So you have that inside the mouth and outside, and then you can simply superimpose those. And now you have a very good virtual plan. And then based on that, you have the outline of the denture, and you can design about the implant position, the locators of all on 4 or whatsoever, and actually gives you a good amount of thickness, and everything would be very accurate.
Every software can do this, or there we need a special softwares to superimpose them on each other, to
There are
merge
so
them.
many there are so many softwares in the market. I think you can any softwares that they read with they read the CT scan. They have the option to import STL file or import the other data point, and then you can merge those together. I'm
You know,
not
because their denture is radiolucent, just at the point of, I think they call it a fiducial balls.
fiduciary markers. Yes, this is a
Yeah,
kind of old-fashioned way.
yeah.
Fiduciary market. These beads actually is a kind of fiduciary markers, but the other conventional way is like they put some gutta percha on the denture, so they make it radio opaque. But again, when you do the scan with the intro scanner, you need the STL file. You need like a 3D file of the denture to superimpose.
You mean every CBCT can do take a scan of something that is radiolucent, just except for the ball, the radiopaque balls. Every CBCT can do this.
They can capture something like that. And again, with these scanners, you even don't need to do a dual scan. They call it dual scan technique. You don't need dual scan. You just need the CT scan with those balls inside the mouth, and intro, like with the scanner that you have in your office, scan the denture inside and outside, and then you open up the software of the CT scan, and there's a point that you can merge that into it. I think ExoCAD must have it too. I'm not sure. I haven't played with ExoCAD much, but there are a lot of software. Blue Sky Bio, I think this is a free source. You can download it. Blue Sky Bio has it too, and you can merge these two together. It's such an easy way. You just need to play with it for a while. But Blue Sky Bio, you can learn how to use exactly. You can exactly do this with Blue Sky Bio. You can learn it from YouTube or any other like their website. They have webinars, and it shows how it could be done. And then they give you the design. The only thing is like Blue Sky Bio lets you do all the designing, but when it comes to export the surgical guide, they ask for money. But you can do all this designing basically. And many times, what you can do the designing, and okay, you can communicate with the surgeon that, okay, I would like implants in canine area or in the premolar area. So when you do your flap, do this. And also you can ask them to do, okay, maybe we need 2 millimeter of reduction in that area. And you communicate better if you cannot do the surgical guide printing.
Thank you so much.
Michelle?
This is again another example. So everything could be superimposed like that. You can evaluate the space.
I think you should turn the play off.
Okay.
Yeah, thank you.
Okay, so it's off again. So this is again another example that that area was bone grafted and the sinus lifting was done, and then you see the outline of the denture on the right hand side picture, and then the implant is placed and designed, and off of that we know, okay, where's the emergence profile, where's the access hole, and then based on that they make the surgical guide. Again, this is another case, and I did this before even I finalize the denture. This is at the waxing trying. When I did my trying with the teeth in wax with the patient approved the look. I said, okay, let's do this CT scan with these beads on, with these speedy markers, just to see if in future you want to go over denture or all on 4 or whatsoever. And I just did the dual scan technique again, and this is how it looks like. And if you see, there's not much bone, and we decided, okay, we don't need to do any implants, because if we do, we had to go to zygoma implants or trigoid implants, which the patient didn't want to go through those procedures. And the denture actually, although like the arch was very flat and resorbed, the denture retention was pretty good, so she was happy about it. And this is eventually what you can use those templates or radiographic template or the duplicate of that CAD-CAM denture. Even the Avident can make you this, not only as a radiographic template, but you can also give it as a guide to the surgeon so they place the implant in the area. So for everything over dentures or immediate dentures, before extraction, you can do the actual model with a stone, regular impression or a scan, and then you design everything like this, and they will fabricate you the denture. And this is like they made a denture with the fiduciary marker, which is like a gutta percha, but you have to make sure when they do the CT scan, these things are inside the patient's mouth as mutual points, so they're able to superimpose it when they want to design or plan it right. And this is how it's gonna look like. This case that I'm showing, basically, it is an all-on-4 case. And again, this company, if you're gonna go fully guided surgery for all-on-4, they can make you the dentures, but not only that, they can also make you that denture that you want to convert with some pre-cuts on it. See, these are pre-cuts that could be made and with the holes, because you're going to follow the surgical guide. So as soon as you put the surgical guide and then secure with the pins, you can do your surgery, and then the implant position will be almost the same area. And those dentures that they mill for you, they are following those holes, so they have already the holes. You just need to put the dentures on top of it. You know, this is how the surgery done. And the multi-unit are placed and temporary abutments on top of it. And this is like dentures that with the pre-existing holes that they were fabricated already. And they just pick it up and that's it. And you toss it away, and then you just fill out the whole area and then finish and polish. And there you go. Everything is made and all done.
In the slides, it looks very fast, but how long does it take in the office?
So so if you have that one, the surgery depends on how speedy the surgeon is. If there's not a lot of bone reduction involved, or there's not a lot of things, usually the surgery with 4 implants, if it's fully guided, as you see here, there's no flap. So this one can go as fast as 1 hour or something like that. And the denture is also pre-cut. So basically you put these temporary cylinders in, and they're already sticking above it. And then you only pick it up, you cut it, you unscrew it, and you fill it up. So maybe the conversion part, which is this part, it can take another 2 hours maximum. So nice. I would say with fully guided, you can have everything done within 4 hours.
Right. For the multi-unit abutments, since you had a surgical guide, do you have a pre-ordered abutment, or you have a different size of gingival height?
Yeah, I have noticed that, well, multi-unit abutments, usually the surgeons, they provide that. And then based on the evaluation that we do, we go with different heights, and you can order it because they come in like 1 mil height, 2.5 mil, and 4 mil, and 5 mil, or sometimes 6 mil. It depends on the company. As much as it comes above this gum line and everything like super gingival, then you're all set. And the surgeon can decide on that. And after this, everything would be super gingival and easy.
Right. There's 2 rationale for the multi-unit abutments. One reason that we use it for the immediate loading is due to the sutures and the blood in the area. So since you didn't have a flap, can we deliver this type of restoration on the fixture level? So
this is the thing that it's not common to do anymore any kind of fixture level all-on-4 type of restorations. The purpose of having multi-unit is, as you mentioned, one is bring everything from subgingival or at the bone level to tissue level and above. Also, these things, they have like a very good taper. They're all conical and non-engaging. So And then they come in different angles, a straight, 17-degree, 35-degree, and some companies, they have come up with some 45-degree angle. So eventually when you put those in, you correct the angulation of the implant. And as you see on the right-hand side picture, all these implants eventually will become all parallel. And then that's how you fix them, and they have one path of insertion and makes it very easy. I've noticed in Iran, I see a lot of cases on Instagram, social media, that there's still a lot of cases done like cement retain and with abutment level, or they do the custom abutments and they cement the whole thing. But here it's not that popular anymore, and everything is like a screw retain. Everything, you screw it on a screw, screw it on a screw it, and you just seal the top, just like something like this, but in a permanent version.
And for the definitive restoration, since you mill the bar for the hybrid prostheses or over denture, do you still go on the abutment levels or?
100%, yeah. So let me show
100%.
you this. This is like different designs that, for example, Avident have. You see, they all have like the abutment level of the connection.
Right.
Everything like that. I'm going to show one more case. What time is it? It's 20 to 12. Okay. Time goes by fast.
Bother you. Sorry. We also have multiple questions. Do you want to answer the questions?
Sure, let's go for the questions.
You know what, Priya, thanks for the lecture. We have a couple of more questions in the chat room, and I offered them. Let's discuss at the end of the lecture. I don't know if you have access to the chat room, but let's open it at the end of the lecture. So please move on. Thank you.
Okay, I'll try to go a little faster. And basically, there are a lot of examples that you can see. So again, these dentures, you can get it as it's called good fit, and you can do wash impression or something. If you look at it in this picture, if the midline is off, you can mark it with a Sharpie and then send it back or scan it, and they will correct the whole tooth setup for you virtually. This is another case, and this is another case. You can also send as a cast, and they on the cast they will work, they will scan, they will fabricate everything, and off of that they can make you the surgical guide and the modeling and everything. So eventually, again, they send you something like, I'm gonna go to play mode again. If it gets crazy, just let me know.
Okay.
All right, move on.
So the surgical guide will be fabricated. They send you the denture with the pre-cuts. And this, the only thing is, like, you never know during a surgery if the implant stability, because you need to load the dentures if the implant stability is great. But if not, then you may end up like not attaching these denture to the implants. So that's the only drawback of having those pre-cuts. That's the only thing.
Yeah, thank you so much. And now, shall we go for questions, Dr.
I think
Is it do you have more slides, Dr. Sultan?
So we have more. Let me go a little fast.
Okay, okay.
For example, this is a case that was a combination of CADCAM and conventional, and only one implant here was about implant level, and all the others were like abutment level. So basically what I did in this case, after I did the conventional tooth setup, we made the design with the GC pattern, and then they milled me the bar. And after that, I sent this to the Avident company, and they made a denture, like a monolithic denture, and they glue it on it. And it's looked like that. This is a one-piece denture. So these teeth and the denture milled at the same time. And this is how it's gonna look like on the occlusal view. And actually, he's a patient of mine, and I saw him recently, and this is after 7 years of follow-up, not much of staining, not that much of wear or something, and it's still very good and fully in function. This is the evidence. They are producing different products. And the CAE hybrid is one of the ones that I'm gonna try soon. And this one basically has the metal reinforcement inside, and the teeth and the metal, it fused together. And it needs much less space compared to the conventional hybrids, just like this one and that one. And it will look really good. And these are again some examples that you can use conventional. And locators would be different locators. If you want to go pallet versus palletless, you have to make sure you have a good distribution between your implants and the arch form is good. And I'm gonna finish up maybe with this case, maybe two more cases, but let me show this and then we go to the questions. So this lady came to our practice. Initially planned for all-on-5, but then one of the implants screw broke, they couldn't retrieve. So they turned into the conventional overdenture. However, the implant placement was not done properly and the implants exposed. Patient didn't want to do anything with the surgery. So we just refabricated dentures. A lot of things was done wrong in this case. Restorative space was very limited, everything fractured. The transition line was showing. And then the hygiene was not good either, and you can see concavity underneath it. And we have a lot of things. So what I did basically, because with the CADCAM dentures, we have more strength, so we can reduce this restorative space and make it like stronger, but with a less thickness. So this is what we did. Basically, they did 3D printing of the metal. And they knew already the implant location. So as you see, this goes back to the question that you mentioned. So they are hollowed out, and now you have room for the healing abutments or the minute locators, and then you pick it up intraorally. And this is the upper that looks like, and this is how it ended up like getting there with such a limited space with a very good strength, so it doesn't fracture or crack.
The slide is going back and forward. Probably is due to play option.
Did you see this case?
Yeah. Now it's a subs. Sorry.
Yeah. So this is the final result. This is like a monolithic CAD/CAM denture, but they design a metal reinforcement inside the denture. So not only strong, but also reinforced. And they hollowed out the areas that the implants and the locators will be placed in. And this is again another case that they call this Wagner train. So they do 3D print this, and these teeth are in wax, just like a conventional, and you can move around the teeth. And you do the bite, you can adjust the wax trim, and you, just like this, you say, okay, I want the midline a little toward the right side whatsoever, and you can fabricate it. And this is another overdenture case that the implants were not placed parallel, the space was tight. So I only ended up like activating 2 of the locators rather than 4. And I got a still decent retention of it. These are some of the recent cases that I've done, but the patient, all these teeth were loose, didn't want to do any conventional impressions. So I scanned everything. It is a fully digital workflow. And the lab fabricated me these type of like restorations. These are, they are called Valoplast, but I think for this one, they use 3D printing, not Valoplast. So these are acrylic and they're relineable. And this is how extractions were done. This is how we ended up having this. This is how it looks like. And this is my sweet patient. She is 100 years old, 100 years old, very alert, a very good patient. I plan to extract this. I extracted that. But again, for this case, I did full arch scan, just like this, but I tried to capture the sulcus as much as possible. But because of her tongue and cooperation, it was hard to capture the lingual area. So what I did, I used her existing partial that she had, and I did a wash reline underneath it. So in that case, look this, and I scanned that one and I send this to the lab, and they made me a 3D printed. They made me a 3D printed partial denture. This is 3D printed. This is not Valplast or something. And it was again reliable and looks very good. This is the case that I said I saw a little thin some areas, so I was a little afraid that I'm gonna break it. And this is how it's gonna look like. Unfortunately, I forgot to take clinical photos. This is another case, again, very difficult case. I'm still working on this case, but again, we did full arch scan, immediate placement after doing some surgeries. This is the 3D printed model. And in order to be safe, I also scanned that. So in case the patient breaks it, because he broke it one time eating steak, I scanned that. And then if anything happened, I can easily 3D print this and fabricate that. And we did all on the lower one. And this is how it's looked like from here to here and here. Everything was like done fully digital. All right, thank you so much. I tried to wrap it up very quick. I know like I went also over time. You're welcome.
Thank you so much. It was very interesting because high technologies and new technologies all were involved in your presentation. And we hope we can have more time and can have more time to one by one ask our questions about the cases and talk about it and discuss about it. And thank you so much, Dr. Sultanzadeh, because I know it is almost your midnight and you have two young kids and it is very difficult for you. Thank you so much for cooperating with us.
You're welcome. I'm open to answer any questions right now. I have a few more minutes if you want, but again, if time is tight, then we can do it for later.
Do you have access to the chat box down there on your screen?
I do.
Okay.
Yeah, I can see some, yeah. So which one you want me to start, which one?
If you go up there regarding the bonding of the denture teeth, it was the question on the top.
The other ones, there is no other one.
I think I lost track of that. If you can read the questions for me, I can answer. They bond the regular monobond and the monomer resin, just regular acrylic resin. They bond the teeth to the denture base, just like the regular ones. Yeah.
Right. Dr. Shahbazi from Los Angeles, he's asking regarding the bonding of the denture teeth to the base, to the milling base, how often it fell off, or it is a complication, or you don't face with that situation? Honestly,
I haven't seen that much of a case, but again, I personally use the monolithic denture, mill dentures, which they're one piece, so they never debond.
Right. So you haven't had this experience?
No, I haven't had it.
And
also, what I've noticed in the digital dentures, they try to avoid deep bite or deep cusp, so they're trying to make it like the minimal amount of overjet and overbite. So in that case, it also help for debonding or too much pressure on those teeth. But I usually use monolithic, but I've done like few like bonded teeth to the denture base, but I haven't had issues with them.
Great.
Also, Dr. Makbari says hello to you from the beginning of your presentation. He says hello to you, Dr. Makbari.
If you remember, he was a former
Dr. Makbari.
Yeah.
And there is another question, Dr. Moin Nejad, he asked regarding taking impression. He's asking that, do you use the locators as a scan body for the overdentures, or you use directly scan bodies?
No, I mean, there are not the scan bodies. It's still like the locators will be picked up into the denture directly, just like a conventional way. So there is no scan body. I mean, I don't know of any, but you can put the locators on, you scan the whole arch, and then when they fabricate the denture, as I showed you on the pictures, they keep those areas hollowed out, and you can conventionally, like chairside, just pick them up.
Great.
Um,
For the audience, if there's
This is another question.
any question,
When we want to use bar,
go ahead, please.
first we have to take impression of implants with scan bodies and then company do the other things. Am I
Yeah.
right?
Yes, for fabricating the bar, of course, you can use a scan bodies because it's implant level. You can do conventional impression, this splinted open tray impression, or you can use the scan bodies, but you have to make sure either these scan bodies are close enough, or you can make some markers or connect the scan bodies, because the errors that come from full arch scanning is the stitching of the images together. So this is different topic, different situation to have a perfect, accurate, full arch digital scan. But overall, when you have that, then you submit it. So they will design the denture, they will design the part, and then they consider which areas they need to reinforce, which area they hollowed out for denture to accommodate the bar inside the denture.
Yeah, so thank you so much, Dr. Sarkhan.
Great, Dr. Priya, having you here. And it was a very impressive lecture. You showed us multiple cases. So I would say thank you to you, and we are looking forward to see you in Iran or
another
next,
webinar.
Next webinar, right?
Sure, thank you. It was a pleasure having you.
We are
Thank you
very
so much.
honored to have you.
It's my pleasure. I love to just see you guys, and then of course we share the knowledge and experience, and then I miss you all. So hopefully I see you back home, or I see you here and host you here, and we go and have some cello kebab together.
Hopefully.
All right. Thank you so much.
Thank you
Thanks,
so
you.
much.
You're welcome. Bye.
Now we move on for the next lecture. The next lecturer is Mr. Raymond Hakubian. He's from Los Angeles, the city of angels. Good to see you. Good to have you here, man. And
hello.
Hi. Sorry for the delay.
That's fine.
We had a lot of problem with the internet in the beginning, and then some issue with the slides. And also we asked Dr. Puya to elongate the lecture because we have one cancellation. So I know it's already late over there. So thanks for waiting.
Sure.
So the topic for Raymond is laboratory workflow, current technologies. Please move on.
Sure. Give me a sec. Just sharing my screen. Okay. Hello. Can you see me or my
Yes, we
share
do see the
screen?
yeah, we do see the slide and we can hear you.
Okay.
Please
Great.
carry on.
That's great. Okay. Hello, everyone. Now, before I start, I want to thank Dr. Sadakus for giving me that opportunity to be here. My name is Raymond, and I'm the president of the Zircon Dental Laboratory, located in Glendale, California, and I have been in the dental industry for over 30 years, starting in the 1990 and continuing to present during this time. I have successfully led a dental lab team and creating high quality dental restoration using advanced technology and techniques with specializing in zirconia, implant and Alonix restoration. From 2006 to 2009, I collaborated. I'm sorry, just don't want to say this. Sleep. Okay, I'm sorry. Yeah, from 2006 to 2009, I collaborated with Zirconzon as Iran's top representative and dealer of their technology. After moving to the US in 2009, I started my own dental lab as a Zircon Dental Laboratory and became one of the first specialized lab in zirconia restoration. I obtained my certification as an ITERO certified trainer from LVI, and currently I'm working with the Sprint Ray as an advisor and starting with them in 2022 to advance their dental technology and provide consulting and product development. Okay, so in a restorative dentistry, achieving an optimal shade match between natural teeth and dental restoration is critical for a successful and aesthetically pleasing outcomes. With an advancement in the dental technology, digital shade matching systems such as OptiShade have risen, offering improved accuracy and efficiency in capturing and reproducing the tooth shade. This lecture will explore that process of the capturing shade using OptiShade, and its application is in matching the restoration to the natural teeth. In the field of the restorative and the dentistry, getting the shade of the tooth just right is critical for achieving a natural and pleasing aesthetic outcome. As we've seen in the shade samples in the slide, getting the optimal tooth shade isn't straightforward as might seem. Tooth shade isn't static and can be influenced by various of internal and external factors, such as age, diet, or certain medication. So also it's important to remember that we are not just matching a single tooth. We need to consider to overall appearance of the patient's smile and how to restore the tooth will be blend well with the neighbors. This is where I'm going to start my lectures with the OptiShade. So this is where OptiShade comes into the play, actually. It's a cutting-edge digital shade matching systems that I'm already using in my dental lab, and I'm offering to dentists to have it. That system brings a new level of accuracy and consistency in a process. By using advanced imaging technology, OptiShade can outperform and conventional shade guide, which are often influenced by subjective factors such as lighting conditions or observed bias. That allows us to more accurately match the shade of our restoration to the natural dentation. Is elimination in inconsistency at traditional shade guides, providing a superior level of accuracy. Here you can see this is one of my good friend is Marat. Actually, he's an inventor of the Matisse systems. I was in his course like 2019. It was a 2-day course. We just been there for like they teaching us to how to use that software and how to capture the teeth shade. And actually Matisse is a 2-day course. I cannot explain it in a 2 days lectures, but just a little explanation. The OptiShade actually is a kind of a camera which is have apps in iOS and just capture the shade, but this OptiShade is going to link to the Matisse software. So Matisse software is doing just make the recipe for the dental technician to how to build the shade for the final restoration, and you blend it together and match with the natural teeth. Actually, this Matisse, actually, it's called a one bake shade matching technique, but there is a lot of details on it, so I cannot just go on it. So I'm going to just explain more about this system. So how does OptiShade work? First, the patient tooth is properly prepared and isolated to ensure accurate shade capture. Then the OptiShade device is calibrated and adjusted according to the manufacturer's guideline, and the shade captures under suitable illumination condition. And the result is instantly displayed on the device screen, as you see. This digital method streamline is a shade capturing process, reducing error that can happen in the traditional visual methods. Once we have the shade, we need to understand the principle of the color as shown in here. Value, chroma, and the hue. Hue is a more pure color. Values is representative of it's a lightness or darkness, and chroma refers to is intensity of purity. This is what OptiShade captures, and understanding this principle is crucial for selecting the matching shade for the restoration. We also need to take into the account of the optical properties of the surrounding tooth and how the restoration integrated with the patient overall smile. Here's the restoration before and after customization based on our shade analysis. Depending on the material we use for the restoration. As I said before, the Matisse, that shows you that material we can use for each case and each shape. This is actually this picture is I took it in my lab. So when we take a shade of the patient, we have that option to comparing what we made restoration. So there is shows us that all that value of the chroma and hue. So what I was going to tell, this is okay. So for the depending, we have different techniques in our disposal, like a layering, characterizing, or even using shade modifiers or glaze. This allows us to create restoration that are virtually similar to or practically identical in the natural teeth. Using OptiShade can lead to a huge result in many clinical sensors, and however, mastering is a usage does require understanding potential challenges and knowing the best practice always. The best practice. Always remember, OptiShade is a tool that we use currently can greatly enhance your restorative outcomes and patient satisfaction.
Excuse me, may I ask a question?
Sure.
If you use OptiShade, you just can use a special ceramic Matisse, or other ceramics like from Vita or other companies can be used too?
The OptiShade is just the tools for the capture the shade. But for the matching, there is another software. What I said, it's called the Matisse. Matisse actually is a link to this OptiShade to give you a recipe to what kind of zirconia to use, or what kind of ceramic you have to use. It's a categorized for you, the Matisse software.
So the Matisse tell you if you want to use, for example, Vita, which shade of Vita you should use with this LAB and
Exactly. Actually, Matisse is give you a map. That map to help you to, layer the ceramic to the zirconia crown, or actually lithium disilicate or whatever. They has a chart on their software. That chart, just help you to choose what kind of zirconia crown do you want to use, what type, what translucency, and what kind of the porcelain you have to use to get that shade matching.
according to the ceramic that you are using, Vita or I don't know, Norifake or
Yes.
anyone.
There is in the chart in the Matisse, there is a bunch of ceramics. You can choose whatever you want and go with that direction.
Okay, thank you so much.
You're very welcome. Okay, so I'm going to actually I finished my the shade matching lectures. I'm going with angle screw channels. So next we will go into the concept of screw channels, how it works. So now we will explore to
Raymond, before we move on with the next topic regarding the optic shades, we saw the hardware. It looks like a camera you connected to the phone. Is it like that?
connected to, I'm sorry.
To your phone, to your cell phone.
Yes. Actually, the optic shade is working with iOS only.
Oh,
So,
just iOS.
yes, iOS. You can have a computer. You can have a cell phone, or even what's called that
Tablet.
tablet. Yes.
Interesting. So it's made by, is it made by Apple or?
No. It's not made of the app. Is just only working on iOS. The optic shade, it's just a kind of camera.
Right.
Which that camera is let me show you. I think I have to go back. You see, this is a cone camera.
Right.
Okay, and connected to your iOS device. When you're capturing the shade, then it give you that shade. All
There
detail.
should be some calibration, shouldn't it?
Yes. That if you see that there is a cap on it with the white surface in, that's calibration cap.
Right.
Every time you have to you start to use it, you have to calibrate.
Right. So it works like a scanner, oral scanner. So it scans.
No, it's not a scanner, it's a camera.
It's a camera. All right.
Yes.
So by this tool, you capture the tooth and you transfer the whole data to the lab technician. Interesting.
It is something like a spectrophotometer or colorimeter. Yeah, it's a very small.
Yes,
Yeah.
it's kind of.
Very small one. This type of camera to be, I asked, yes, it has to be calibrated.
Yes.
Yeah, Dr. Shahbaz is asking regarding the calibration, which you already mentioned that every single time that you need to calibrate before using.
Yes.
All right.
Actually, when it comes, I think I bring it I brought it to show you guys, but it usually caps on the top. When you connect it to your phone, you should turn it on. When you turn it on, you have to calibrate it for each time of use.
All right.
Let me show you. This is I don't know, you can see it. This is the cone camera, and this is a cap.
Would you please bring it forward so we can
see it.
Yeah.
All right, perfect.
You just put it in a patient mouth, but
right?
the patient has to be keep their breath because it's going to be foggy. It's breathing
Right.
in the camera's cone. It's when you connect it to the phone, it's automatically getting on. And there is a bottom in here. When you push it, it's going to be calibrated. And also, you have that all features in your phone also to calibrate, to take a picture. This bottom is to take a picture, and you also can use your phone to take pictures or calibrate. And there is a bunch of information. You can put your patient name, if you want to put a note or whatever. And there is a chart. You can choose your shade guide. You can choose the 3D master. You can choose the bioform, classical, Vita, whatever you want. There is actually, I think 6 or 7 different shade guide.
How long has it been in the market? Is it very new? I haven't heard about that.
Oh, there is a market. Yeah, there
No.
is.
No, I mean, since when they
Oh,
launched
since
it in the
when?
market?
It should be, I think, is 2-3 years.
2 or 3 years. All right.
Yes.
All right.
I'm already suggesting for my dentist to buy it, but if they don't have, they just refer the patient to our office, and we take the shade and do the rest.
All right. And would you inform us regarding the cost of the OptiShade? How much does it cost?
It should be $2,000 almost.
Almost 2,000.
Just a cone and wire, and there is a extra cone. I think is that 4 or 5. You can just change it.
All right. Thank you.
You're welcome. So let's go. Okay. Okay, now I'm going to explore the innovative solution of the implant prosthesis angled screw channel, which is called ASC. This unique system is crucial for the handling and challenging situation with unfavorable implant angulation. By employing ASC, we can optimize both static outcomes and accessibility in the screw access hole. A real benefit with managing the complex restoration. This ASC system operates by using a creative structure of 2 parts, the abutment and screwdriver. We can tilt the pathway or channel up to 25 degrees from the straight line of the implant. This degrees of the freedom allows us to reposition the screw access hole to more palatal and occlusal location. This flexibility actually lets us to shift the hole we use to fix the tooth to better place, more towards to a roof of the mouth or chewing side. By doing this, we cut down on the overhang towards the cheek and known as a buccal cantilever. This can help share out the force from the biting and chewing more evenly. It's a very importantly can lead to better looking result with ASC. ASC is especially useful in cases with unfavorable implant angulation, particularly in the anterior region. Its innovative design enable us to avoid the buccal screw access hole, therefore overcoming a common clinical challenge. As shown is this image, which is my real cases in the lab. ASC help us improve both aesthetic and functional loading, all while maintaining the advantage of screw retained restoration. Let me see, there's a picture. Yeah, this case actually It was, the patient lost a lot of bones. We're using like 30 millimeters zirconia, and actually it was a facing. It wasn't a full zirconia restoration. If you see it, there's a lot of height on the zirconia. So when using angulated screw channel, there are several important tips to keep to mind, ensure the optimal result. First and foremost, you must see the right tools. Each ASC system comes with a special screwdriver. It's essential that you use this as a regular screwdriver won't work because of the unique design of the abutments. Next, pay attention to the torque setting. The torque is a force you to use tighten the screw. The manufacturer usually provide a specific guideline for this. Is a crucial to you follow these guidelines to prevent damaging the implants or the abutments. Another important aspect to remember is to confirm that the components are seated properly. This means checking that the abutment fits securely in the implant and the screw is correctly aligned with the screw channel. You can do this visually, but also feel for any resistance when you tightening the screw. You can feel that. It might seem challenging at the first, but especially if you are used to traditional screw retain restoration. However, once you get to hang of it, you will find that ASC system offers a significant advantage with the careful hanging and the solid understanding of how the system works. The angled screw channel can prove that to be powerful addition in your restoration toolbox. In conclusion, angled screw channels provide us with the ability to deliver screw retain restoration, even in a challenging clinical situation. From the lab perspective, it means we can provide our dental partners with a solution that offer optimal aesthetics and function. By using this advancement, we can work together to deliver superior patient outcomes. Our decisions continues with look at the traditional analog dental procedures, which hold an important place in the world of full arch implant restoration. These procedures involve creating a plaster model from the impression of the patient mouth, a process that can be several weeks. Today, we will walk through the upper full arch All-on-X case, highlighting the steps involved in analog procedures. As we go in this journey, it's important to note the pros and cons of the analog versus digital procedure. While analog methods have been time-tested in the reliable, they often require more time and can be prone to human error. Conversely, digital processes are generally faster and more accurate, but require specialized equipment and training. Let's start from the beginning. This is my actual case of the lab. Taking a tissue level impression with the custom tray. After impression taken and plaster model is created, replicating the soft tissue and the implant position is here where our first crucial decision comes into the play, selecting the operative multi-units apartments, or it's called MUA. MUA plays a crucial role for full arch restoration. The design of this abutment can greatly influence the direction of the screw channel. By taking a tissue level impression and creating a detailed plaster model, we can design MUA that position the screw channel away from the buccal surface. These techniques, while requiring careful planning and the design, ensure the optimal aesthetics and functionality. Following the design stage, the MUAs are milled from titanium, and then we anodize it for durability. These are sent to the office for the placement and torquing. Then the final impression is taken with the custom tray and MUA impression coping, as you see it in the last picture was here. Yeah. And this process allows for any necessary adjustment before the create of the final restoration. If you can see in the picture, the left side of patient, the screw channel of the implant, yeah, and the screw channel of the multi-unit is in a different, actually we just move the direction of the multi-unit abutment. The good point of the multi-unit abutment, you can move whenever you want and put the correct position. Is not going to be interact with the buccal teeth of buccal side of the restoration. Okay, before creating the final restoration, we send the bite blocks and record and with actually such as actually we get a record for the final impression to get the flex plane, midline, and lift port, video, VDR, and the incisor display. These records are crucial and ensure that the provisional and the final restoration meet the patient function and aesthetics needs. The provisional restoration is then fabricated for usually the next day in delivery. This is and the picture actually shows how we just creating that color with the paint coloring. I use the Showfall company's coloring paste for the finalize the case, then glazing. Actually, we are doing the stain and glaze. Okay, for the next pictures, we have two options for the creating a provisional restoration. We have a milling and 3D printing. Milling, the time consuming often provides a superior durability and aesthetic, but the 3D printing, on the other hand, is faster but does require more technical skills. It's important to consider these factors when choosing the best method for each individual cases. Fabrication All-on-X restoration commonly occur around the thigh base area. Due to the insignificant thickness of the handle pressure, to mitigate this, we can use a Rosen screw, as invented by Dr. Dan Rosen. The Rosen screw with the unique geometry locks into the screw channel, as shown the picture, prevent to the losing and can be torqued up to 20 Newton centimeter with any material, like you can made it with any material like a resin, PMA, or zirconia. And as it shows in the picture, the top one is with the multi-unit and the bottom one with the Rosen screw. As you see, the Rosen screw one is the thickness of the appliance is more than the thigh base one. With the professional place in the patient's feedback gathered, we are ready to create the final restoration. This could be full zirconia or titanium hybrid or a PEEK hybrid with the zirconia material. This material offer durability and statics with meeting the unique needs of each patient. In a conclusion, the analog procedure for all Alex cases through the time consuming allows to great flexibility and customization every step, from impression taking to the final restoration. And crucial of the success of the procedure, we detailed planning, execution, and collaboration with the dental professional. We can deliver a superior result that meet patient needs and expectation. Okay, but there is a caveat, so I'm going to introducing my next lectures about photogrammetry. Okay, with the advent of the photogrammetry within the dental field, a huge change was brought, allowing for the faster procedure with the same high quality. Photogrammetry is a simplest themes, is a process of the making a measurement from photographs in the world of the dentistry. This technology is revolutionizing way from we capture dental structure, creating the way for digital impression that are highly accurate and efficient. The iMetric iCam 4D is a leading device in the domain. It uses for a unique camera system to capture geometry of the dental structure, offering the level of detail that truly remarkable. One of the critical aspects in a dental restoration that we need to capture, comprehend, and the concept of passive fit. The passive fit refers to be a perfect alignment of the prosthesis with the underlying structure, such as the implant, without the mechanical stress or tension. This harmonious fit of apartment and ensure the longevity of restoration and reduce the risk of the complications. When the dental restoration achieves a passive fit, it's not just about the comfort. True, that's certainly a key of the benefit. This perfect alignment minimizes the stress of the patient's bone structure, keeping the overall oral head and making sure that the restoration performs as naturally as possible. One of the other's hand in the restoration doesn't achieve a passive fit. It can lead to a range of the issue from discomfort and difficulty of chewing the more serious problems such as a bone loss around the implants and eventual failure of the restoration. As a dental professional, our goal should always to achieve a passive fit with our restoration, enhancing the patient comfort and ensuring the success and longevity of our work. As you see the picture, the passive fit, if it's not correct, then it's affect to the breaking the bridge and restoration. Okay, so now that we understand the importance of the passive fit, let's discuss how we can effectively achieve it. This is where the technology of photogrammetry comes to play. Photogrammetry is especially when using device like a iMetric, iCam 4D can significantly improve the accuracy of our measurement and models through enhancing the passive fit of our restoration. The iMetric iCam 4D captured thousands of the reference points on a patient dental arch. This detailed data allows us to create an incredibly precious 3D model that perfectly aligns the patient actual anatomy, ensuring a seamless and a stress-free fit for the final restoration, which is the cause of a lot of problem. By incorporating with the photogrammetry into our workflow, we not only streamline our process and improve accuracy, but also significantly enhance the quality and the fit of our dental restoration. This commitment to accuracy and fit facility by technology helps us achieve better patients' outcome. In incorporating iMetric, iCAM 3D, and photogrammetry into your dental lab workflow might sound intimidating, but it is in fact quite straightforward. By becoming these technologies with our traditional practice, we can improve the overall efficiency and accuracy to our work. Essentially, digital impression captured through the photogrammetry replace the conventional impression, leading to enhanced accuracy and the speed of the restoration process. This transition to the digital workflow can bring substantial benefit, leading to better patient outcomes and more streamlined laboratory operation. Now, 3D printing technology bring a huge benefit to the table when it comes to the dental restoration, especially for provisional restoration. There is a faster, more cost-effective solution with excellent accuracy and aesthetics. With the 3D printing, we can produce a provisional restoration and a fabrication of the time it would be taken using traditional method without any comprehensive on quality. But it's not just about speed and cost. The precious precision of the 3D printing allows us to create restoration that fit perfectly, providing the patient with a comfortable and essentially pleasing result. So by integrating 3D printing with the sprint tray into our workflow, we can significantly enhance our productivity and the quality of our restoration, ultimately leading to higher patient satisfaction. In the left side of picture, just I printed the provisional for one of the patients with it's a 3D, it's a spring tray material. It's called crown, which is the almost more than 50% nano ceramics on it. So for making more harder. So through these lectures, we are covered into several innovative technology and techniques that are reshaping that field for dental restoration, from the precision of the dental shade matching with the OptiShade and flexibility offered by the angle screw channels and the custom Muta units, to the precision and reliability for Alonix analog precision enhanced with the Rosen screw. We are also highlighted how photogrammetry, particularly through the tools like the iMetric, iCAM, 4D, can enhance the passive fit to our restoration, increasing the patient comfort and the longevity of our work. And the special, I just want a special thanks for Dr. Joe Meranfar for providing us with some pictures for the presentation. Furthermore, we have taken a brief look at the benefits and the potential of the digital dentistry and the 3D printing with the impassive of the sprint tray compatibilities, which enhance to the speed and quality of provisional restoration. As a dental professional, it's paramount that we stay abreast of this advancement and consider how we can incorporate them into our practice by embracing this technology. We can enhance the precious and efficiency and outcomes to our restoration, ultimately the leading and improve the patient satisfaction. Thank you for your time and attention today. I hope that you found this presentation information and inspiring, and we continue to strive for excellent dental restoration. I'm happy to address any questions through the mail to have now.
Thank you so much, Raymond. Although it was very late for you, but you cooperate with us, and we do have a couple of questions here.
I'm sorry, I'm kind of sleepy tonight. If I
Yeah, I know, because it's very late.
Yeah.
And it's Sunday night. Probably you have to wake up early in the morning. There's a question Dr. Shahbazi is asking regarding the autoclave ability of the.
I'm sorry, I can hear you well. Just let me just bring up the.
If you go to the chat box, there's a question by Dr. Shahbazi. Do you have access to the chat box on the
Okay, just
on your screen?
Okay. Let me see which one is the from Dr. Is it autoclavable? Okay. Well, which part is autoclavable?
I think
are
he's
you talking
asking
about
regarding the OptiShade. Does it need for
No,
sterilization or?
no. Does not need to autoclave.
Since it doesn't touch the tooth, so probably there's no
Yes,
need for that.
you don't touch the teeth. You
Alright.
just captures in like maybe 2 to 3 millimeters. And you can use the alcohol pad for just clean the surface, but it doesn't need.
Thank you so much, that Mr. Hakubian. It was very good and informative. I hope we see you again next time.
Sure. Thank you for having me.
Thank you for accepting our invitation, Mr. Hakubian.
Sure.
Thank you, Raymond.
Pleasure.
Hopefully see you soon in Los Angeles,
Sure.
In Iran.
or maybe here.
Sure. Why not?
Sure. Keep in touch, and thanks a lot.
Thank you so much. Take care. Good night.
Have a good one. All right, right now we are moving to the next lecturer, Dr. Parhiz. He's back. So we have a changing in plan in the schedule for lecturers. So Dr. Parhiz, since he's available now, I would like to ask him to join us. And his topic is 3D printing in dentistry, exploring the new horizons. Dr. Parhiz, please move on.
Thank you, Doctor. Hello, everybody. First of all, I have to excuse because I have a cold and I have a hoarseness in my voice. I have to say that I'm honored to be here today at this event, and I would like to say my appreciation to the executive team, especially Dr. Farid. And I hope today I can complete my my presentation. Thank you so much. Now my lecture is about 3D printing in dentistry by looking at the future and the present trends in 3D printing. I'm Dr. Ali Reza Parhiz. I'm maxillofacial surgeon and I'm associated professor in Tehran University. Okay. In this presentation, I will talk about, first of all, what's the 3D printing, or what's the story of 3D printing dentistry, different type of 3D printers, and also the materials which are used in 3D printing in dentistry. If we want to define the 3D printing, I have to say that it's an additive technology to create an object, a physical object, by putting the materials in layer by layer. It means that in the software, special software, we slices the objects and then we can create these objects by special materials. It doesn't matter, it can be metal, it can be resin or something like that. It was in 1990s that the first dental printers, 3D printers entered the world of dentistry, but it was in 20s that some of affordable 3D printers, especially DLP, developed in dentistry. And interestingly, it was in 2010s that the SLM printers that could make objects directly by metals entered to the world of dentistry. It was really a revolution and in this technology. I want to mention three different types of 3D printers, which are much more useful in dentistry or the most common in dentistry. The first of them is FDM, which is the stand for Fused Digital Modeling. In these printers, the material in the form of filament are going through a heating nozzle and they can put on each other layer by layer to create an object. We have sliced it already in the softwares. But there is a drawback for these printers that's in the resolution and accuracy of this printer are almost lower in compared with other two, for example, DLP and SLM. So these kind of 3D printers are useful or usually used to create dental study models or skeletal study models as well as whitening trays. The next is DLP printers, digital light processing. In this kind of printers, we have a reservoir or a tank of resin in which each layer is cured by a source of light. In DLP, we have a source of light. It means that it can cure a surface totally in comparison with SLA printers in which they use laser to cure the resin. Because of high resolution and good quality and accuracy, these kind of printers are used to create and fabricate implant surgical guides, delicate dental models, and also surgical cutting guides, orthogenetic splints, and temporary or permanent crown, and orthogenetic clear aligners, in which I will talk about them in later slides. The third one is SLM printers. It's very interesting. I want to show how SLM printer can work by this clip. Let's see this clip. We want to create or fabricate such these objects. First of all, we have to slice this object in the software. We can create different slices and then now we can see we slice the object in the software, and then we can make each layer by laser, which is exposed to the metal, which are coming in different layers. Okay, each layer is laid down on the previous layer because the metal is melted and fused to the previous layer. And finally, we can create such these PSI for the mandible. This is a real case we have done already. This is a hemi-mandible prosthesis for the patient who was candidate for mandibular resection because of tumor of the mandible. This is made by titanium. Okay, because of the high resolution and good quality of production, this kind of printers also, we can use SLM printer to create and make dental crown and bridge, and most especially to fabricate PSI or patient-specific implants. This is one of the patient-specific implants. Okay, 3D printing has a lot of benefits, but I want to mention two of them. The first of them is that it can increase the precision of our treatment. So the outcome is a rising of patient satisfaction. The second is that we can reduce the time of this the treatment, because most of planning is done before patient coming to the office. That's why we can reduce the time of treatment. And also it's very cost effective because in compare with, for example, milling machine to fabricate some object, it doesn't have any waste material. So it can reduce the cost, and this reducing the cost can be passed to the patient. There are different applications of 3D printers in dentistry. Most common use is in fabricating dental restorations. Maybe one decade, 10 years ago, making dental crowns or permanent dental crowns was not done by 3D printers. Most of them was created or fabricated by milling machines, but nowadays we can make such this crown and bridges by 3D printers with high quality. Also, we can make clear aligners. As you know, nowadays it's very trend among the patient and orthodontist. They can stage the treatment plan of the patient in, for example, 5 or 10 stages, and they can design and fabricate a clear aligner for each stage. Then the patient have to use these kind of clear aligners, for example, 40 hours a day, and after a while, without using any bracket and wire, the arch of the teeth are aligned, and most of orthodontic problems are solved. Another application of surgical 3D printers is to create or fabricate implant surgical guides. It's very useful, especially in implant surgery. Besides the implant surgical guides, we can also design the guides for bone reduction. It means that we can control even how much we want to reduce the bone before the patient comes to the office. We can design all of these guides in software, and we can control all the conditions that would happen during the surgery. Let me show you clinical cases of a surgical guide for dental implant. It was an old lady who referred to us for dental treatment, for implant treatment in the posterior mandible. As you see, unfortunately, we don't have enough height of bone in the posterior, especially in the site of first and second molar. So we decided to do inferior alveolar nerve transposition in company with implantization. After fabricating or designing the dental restoration, we can define the position and angulation of dental implants in according to the processes, because the implant treatment is process driven. And then we define the position and angulation of implants, then design these kind of surgical guides in according to the previous mentioned implants. But it was not a usual surgical guide, but also it was a guide to trace the path of the nerve, the inferior alveolar nerve also. It was very interesting surgery. By a crestal incision in the mandible, we exposed both the inferior alveolar nerve in left and right side because we want to keep it safe. That's why we expose it completely. Then we put the surgical guide in the mouth and put in the guide. As you see that the guide can preserve the nerve. Sorry. In the left and right side, and we use a round board to define the path of the nerve by minimal bone reduction. And after that, we extract the nerve totally from the canal. And as you see, we put 2 implants and do nerve transposition by very low and conservative bone reduction in both sides, left and right. The implants are inserted in the position we have. These are already in the software. Okay, let me show you something about the workflow of dental implant surgical guide creation. It has 4 stages: data collection, computer-aided design, and computer-aided manufacturing, and finally to deliver the product to the patient. Doesn't matter surgical guide or crown. In data collection, we need 2 kinds of data. First of all, is CBCT or spiral CT, which can show us a whole anatomy of the face, lower jaw and upper jaw, and also the relation of the teeth to each other. and also the position of any landmarks, anatomic landmarks like inferior alveolar nerve and sinuses and the floor of the nose. The second data we need to design a surgical guide for a dental implant is to have the relation of the occlusion. We can have such this data by using dental models and scanning in laboratory scanners or using intraoral scan to have the occlusion completely, as you see here. The second stage is to computer-aided design. As I told you before, the implant treatment is a process-driven. So we have to fabricate and design the crown first, and then we can put the implants in the correct position. It means that the factor that can define the position of the implant is not the available bone, but also it's the position of the future crowns and bridges. Then in the CBCT, we can assess the position of the mandible three-dimensionally. It means we can assess the position in according to the adjacent teeth and root, and even by in relation with different anatomic landmarks, and also buccal and palatal-lingual cortical bone. And very interesting, we can see if the implants are in parallel direction to each other or not, and if one of them is out of range or not. And another interesting thing that we can increase the safety of the surgery, because in the lower jaw, in the mandible, we can also see the position of the implant in according to the inferior alveolar nerve, so it increases the safety of the surgery. That's another beneficial of using digital planning in treatment of in implant treatment. Also, in this case, you can see we can predict to do GBR for this patient, because we have some bone resorption here. So before starting the surgery, we can plan for doing GBR in company with implant insertion. Okay, in the third stage, we go to the computer-aided manufacturing using different kind of printers, as I mentioned before. Most commonly useful is DLP printers. And according to the support of the implant surgical guides, we can classify them into three categories. First of them is two supported surgical guides. These are very accurate and very precise surgical guides. In this kind of guides, if you don't need any accompanying procedures like bone grafting or sinus lifting, you can do whole the surgery flapless just by punch technique. It's very easy, and it can reduce the whole time of the surgery. Then the next one is tissue-supported surgical guide, but you compare with the previous one, it's not as precise as the two-supported, because in the soft tissue is resilient and it can be compressed during putting the surgical guides. By the way, we can fix these kind of surgical guides using anchor pin. Here we have fixed it by 3 anchor pin here, and you can do the surgery completely flapless. This kind of surgical guides is useful, especially for patients who are completely dentureless but do not need any other surgeries for bone grafting or sinus lifting. The third one is the bone-supported surgical guides. It needs a big incision, a huge exposure. This kind of surgical guides are used in patients who need, for example, different techniques of bone grafting. Doesn't matter, GBR, ridge splitting, sinus lifting. And in compared with two previous mentioned surgical guides, is much more aggressive. That's why most of surgeons prefer to avoid such these guides. Another application of 3D printers in dentistry is to design and fabricate the orthognathic surgery splints. In this clip, I will explain how we can do an orthognathic surgery in a patient who needs 2-jaw surgery. In biomax surgery or orthognathic surgery, we try to correct the relation between maxilla and mandible. We have different kinds of occlusion, class 1, 2, or 3. You know, it's better than me. In orthokinetic surgery, we start with the maxilla, which means we can advance or set back or push back the maxilla as much as we want, according to the treatment plan. So after reposition of the maxilla in any direction we want, we need an object to stabilize this new position. After stabilizing the new position, we can fix the maxilla to the mid-face. That object is splint, orthokinetic splint. We name it intermediate splint. This splint can cover the occlusal surface of all teeth and mandible and maxilla, and define the new position of both jaws together. And after defining this new position, okay, now we can fix it by using plates and screws to the mid-face. This splint is, after designing, can be fabricated by 3D printers, mostly DLP or maybe SLS printers. As you see in this patient with a huge anterior open wide, after the BIMAX surgery or 2-jaw surgery, with using these 2 splints, intermediate and final splints, this is the final occlusion. Another application of 3D printers is very interesting to making cutting guides. These cutting guides is it's very useful, especially in patients who had pathologic lesion of mandible. Let me show in a clinical case here. It's a very young lady, 18 years old lady with a history of pathologic lesion on the right side of mandible. Of course, it's a schematic picture, but after designing this cutting guide can help us to define the safe margin for the lesion. The safe margin means the distance between the border of the pathologic lesion and the amount of intact tissue we have to remove to prevent future recurrence of the pathologic lesions. So in the CBCT or sphericity of the patient, we can exactly define of this safe margin, because it depends on the nature of the pathologic lesion. For example, in amyloblastoma, we need at least 1 centimeter of safe margin. After resecting the lesion, now we can see the clinical result of this treatment. All the procedure is done intraorally. After exposing the lesion, we put the surgical cutting guide, and here we use a saw to cut the mandible. And the mandible is separated from here, and then remove all the pathologic lesion from the condyle to the second premolar. Okay. Maybe the most interesting for me, because of my specialty, is to fabricating PSI, patient-specific implant for reconstruction. There are different kind of techniques to reconstruct pathologic lesions or even trauma patients, but one of them is using PSI. Of course, it has its own special indication and contraindication. We have to pay attention to correct patient selection in this treatment plan. I want to mention here also 4 or 5 cases here. This is she's an old lady with a benign but aggressive lesion of mandible. She refuses to using iliac bone graft to reconstruct of the mandible, because the conventional treatment of such this pathologic lesion of the mandible is using reconstruction plates in company with iliac bone graft, but the patient refuses to use the bone graft. That's why we decide to design and fabricate the PSI. After assessment, hold the CTs and radiography of the patient, we start the surgery using X-ray approach through the neck, and after exposing hold the lesion and the tumor, we use a cutting guide to define the safe margin, and then using saw to cut from the correct position, and extracting hold the lesion from the mandible and using these treatment plan for hair. This is a real PSI, which is fabricated by SLM printer by titanium. It's made of titanium. And then we put the whole process, the PSI here in the place, and finally we suture all the muscles, especially suprahyoid muscles and genuglossal muscles to the plate, because we want to require once the patient have function immediately after the surgery. I will show you in the next slides. And the final result immediately after the surgery, and the follow-up radiograph after 2 years. And now you can see how she can talk immediately, just maybe 10 hours after surgery. Just it's a little bit after the surgery, she can talk completely and easily. Oh, sorry. Sorry for this.
No problem, doctor. Take your time, please.
Okay. And this is a follow-up of the patient after I think 2.5 years later. There is no sign of infection, exposure, or deformity in the face of the patient, fortunately. The second case is a young man with a story of severe trauma to the mandible and maxilla. In the first surgery, we fixed all the fracture part of mandible and maxilla, but unfortunately, he had an avulsion of the left side of maxilla. She come back and wants me to reconstruct the side. So I decided using and designing these PSI for him, not only to fabricate, to rehabilitate the occlusion, but also to reconstruction of the malar region. We started the surgery intraorally using and exposing whole the maxillary bone, putting the PSI here. And this is the final result after 2 years. These are new teeth in the position. This is after 2 years, almost. And this smile shows that the patient is so satisfied. The third case is a young lady with a story of severe maxillary atrophic ridge. Also, she refuses to do iliac graft surgery and sinus lifting. We also designed a subperiosteal implant for upper jaw for hair. After assessment, the CBCT, we designed this kind of subperiosteal implants with fixed abutment. And after designing, we fabricated and doing anodizing to change the color in pink. All the surgery is done intraorally, and putting the subperiosteal implant there, the abutments are exposed, and this is the final result after delivering the restoration to the patient. The fourth case is it's a man with story of gunshot and doing 2 unfortunately unsuccessful surgery before coming to me, referred to me to the reconstruction of the orbit and zygoma. So we designed these 2 parts, PSI for him to reconstruct the reconstruction of the orbit, orbital floor and zygomatic arc and malar region. These are the photos before the surgery. We started using previous scars on the face and putting these PSI here in 2 parts. And this is final result after just 1 month. This is the 1 month post after the surgery. But very interesting, we use a navigation in a company with PSI here in this patient. Was very interesting for me, maybe for you, I don't know. Using the navigation helped me to see live during the surgery if the PSI is in the right position or not. See the clip here. We position, it was moving the first part. What we can see on the screen immediately in the operation room to see if the PSI is in the correct position or not. So using this navigation, we can assure that the correct position, if the PSI is right place or not. The last case I want to mention is that the previous one with the story of amyloblastoma, the young lady. She was at that time 18 years old, but now she is 22. And now he's a student of medical science in Kermanshah. Okay, we use surgical cutting guides as I showed you before, and using the PSI to reconstruction of the missing part of the mandible. The whole surgery I mentioned before is done intraorally with no skin incision. After resection of the mandible and removing it, we put the PSI we have designed before that by mirror technique. It means that this part is completely symmetric to the intact part in the left side, because we can make and design this PSI by mirror image from the opposite side. And immediately after the surgery, you see there is no asymmetry in the face, there is no skin incision, there is no suture on the face. And now she's 22 years old. Okay, 3D printers also, not only they have advantages, but also have some limitations. They can improve the accuracy, the precision, they can reduce the time of the treatment, they can really lower the role of the treatment plan because they're so accurate. And the most important is that they can offer us a customized treatment plan for each patient. But the limitation are that they are higher. Sometimes they can have some much more cost. In some cases, in complicated cases which need complex design or fabricating or using special materials, okay, it can rise the cost of the treatment plan, but mostly it's much more cheaper compared with traditional methods. It maybe sometimes it has some lower quality, just in compare with milling machine in producing some crowns. In these cases, we can say that it has low quality, but in other parts, no, it has very high quality. Maybe the most limitation is that some materials are not printable. And I think in a very close future, this problem will be solved. And also after exiting the product from the printer, it needs some additional finishing work. Okay, the 3D printer is the future of dentistry, and also it can improve in the future. The materials we can improve, so the accuracy and precision of treatment plan also can rise. Accompany AI with 3D printers, it's a revolution. They can automate the production of all dental products we need. And also maybe soon, very soon, all these applications will be expanded. Now, okay, thank you for your attention to my presentation. I'm ready for any question if you have. Thank you so much.
Thank you so much for accepting our invitation, Dr. Parhiz, and thank you, despite of your catching call, you still come here and have your presentation. We are so grateful for
I appreciate you, Dr. Fari. Thank you so much for give me this opportunity to be in this event. Thank you so much.
With the presence of lecturers like you and our other colleagues, and this program, I think, was excellent. I mean, every one of our lecturers were great, and you were great also. Thank you.
I appreciate it. I appreciate it. Thank you. Thank you so much.
I don't see any question in the chat box, and I don't want to bother you because of my questions.
See you soon. See you soon. Bye.
See you دکتر من بگم چون که ما نداشتیم اصلا بریک. Our dear audiences, because we didn't have a break today, I think we should have small 15 minutes break, and after that Dr. Jabbari will continue our program with the individualized titanium mesh. So see you in 15 minutes. Hello again, our audiences. Thank you for staying with us. Our last lecturer that kindly accepted to extend their presentation are Dr. Irfan Jabbari and the cooperator with Dr. Jabbari, Dr. Shiazadeh, both are here. Dr. Jabbari is a prosthodontist, also implant fellow, and he's now passing the implant fellowship course in Tehran University of Medical Sciences School of Dentistry. His topic is individualized titanium mesh. Dr. Jabbari, the screen is yours. Please start your presentation.
Thank you very much. Good day, ladies and gentlemen, dear colleagues and audiences. I'm honored to be with you at this program, and today I'll talk about titanium mesh and implant dentistry, and hopefully it will be useful for us. Dr. Shiazadeh, my dear colleagues, who will be with me to explaining the figures and answering questions. Well, titanium mesh nowadays, because of its good characteristics such as high stiffness, low density, and corrosion resistance, and good biocompatibility, are used in the dental and implant dentistry. High strength and stiffness enable us to support for there's overlap between this window and sorry, everybody. Thank you. High strength and stiffness enable us to support the osteogenesis and to enable to support spaces, and elasticity can reduce the pressure of the oral mucosa, and a good plasticity improves the adaptation to various bone defects. Thickness and porosity of are the key factors affecting the mechanical properties. Studies suggested that thickness of titanium affected the total amount of new bone formation. About pore size on the implant titanium mesh, pore size may affect the proportion of the bone tissue and soft tissue formation under the titanium mesh. I can change the slide. Slide doesn't change. The thickness of titanium, which is directly proportional to its mechanical properties, and the commonly range of pores are about from 0.1 millimeter to 0.6 millimeter currently, and the usual thickness is 0.2 millimeter that can be used for most of instances. Under this thickness, the titanium mesh provides sufficient stiffness, maintain the space and protect the grafts, and appropriately flexibility that reduces the risk of tissue rupture. For the thick titanium mesh, there are often some sharp edges in the process of bending titanium mesh due to decrease of plasticity, which is closely related to mucosal rupture. Studies showed that 100 to 200 micrometer is the ideal thickness of the titanium mesh to reconstruct the large number of bone defects. Rakimata et al. Compared the different thicknesses in the bone augmentation in 20, 50, and 100 micrometer. The titanium at the thickness of the 100 micrometer can achieve more extensive bone regeneration effect. About pore of titanium, pore in the titanium mesh, the pore of titanium mesh is thought to play an essential role in blood supply, but there is no selective infiltration. But the pore has an important role in blood supply and facilitating metabolic process. Coletti et al. Demonstrate that without the presence of the pore on the titanium, which the exposure will be likely, and exposure in 3 weeks after surgery maybe appear. Difficult to achieve selective cell isolation, as I mentioned previously, because there is no selective filtration. It is difficult to achieve cell isolation, and soft tissue often grow under titanium. Many studies have attempted to investigate the relationship between the pore size and the amount of the soft tissue growth. Study compared in a study the comparison between two diameter 0.6 millimeter and 1.2 millimeter showed that the larger one promoted more bone regeneration and prevented the soft tissue growth. On the other hand, another study showed that the use of titanium mesh with a large diameter, more than 2 millimeter in diameter, lead to more soft tissue growth upon the surface of the new bone. A similar result for GBR with other materials such as polyester mesh in the different pore size. As we mentioned previously, the larger pore size of the barrier membrane, the more connective tissue. The more rapid bone regenerates, the pore size doesn't make much difference to the amount of bone formation after osteogenesis stabilized. What about biological properties? Titanium has a good biocompatibility because of two issues. The corrosion resistance and cytotoxicity. Titanium has no cytotoxicity, no metal particle release. Low electrical conductivity causes an inert oxide layer over the titanium mesh, which is passive inert oxide layer that can be retained under the human pH environment, leading to high and persistent corrosion resistance. About releasing the metal particle can be released while titanium particle has no significant effect on the human cells relative to growth rate. A thin layer, almost 1 to 2 millimeter thick, the soft tissue can be found underneath the titanium mesh, which is called pseudoperiostom. As we will talk later, this pseudoperiostom, this soft tissue, can act as a barrier, defense barrier to prevent contamination of the bacterial contamination. The formation of this tissue layer may be retained to insufficient cell exclusion ability of the titanium due to pores. Well, you can see the formation of the pseudoperiostom underneath the mesh titanium. So here is the application of the mesh titanium, which will be filled the space by the mixture of the autogenous graft with, for example, xenograft. In the implantation, in delayed or simultaneous implantation, in delayed implantation, we can augment 4 to 5 millimeter in width and 5 to 7 millimeter in bone height. In simultaneous implantation, although there is a few research about these issues, but almost we can gain 3 to 4 millimeter average in bone gain. A comparison between compare the other method. Bone resorption due to infection is rare, and the application of titanium, which has a small amount of pre-implant bone resorption, is usually occurs. I mean, the rate of infection is rare. The rate of the subsequent bone resorption is almost rare. In a Zhang study, they showed that a single anterior defect during the 41 months follow-up, and the average of absorption was 0.8 millimeter in vertical and 0.1 in the horizontal. And in another study by Poli, they showed with a GBR with titanium mesh, the resorption was 1.7 in mesial and almost 2 millimeter in the distal. In comparison with the other barrier membrane, the titanium is the only one which is made by all metal and has a good characteristic and is maintained the space of the for the graft. Constantinides compared the effect of the collagen membrane and titanium for the vertical bone augmentation in collagen group. They gained 2.7 millimeter in bone height, but in the titanium group, they gained more bone in height, almost 4.5 millimeter. It shows that the preference about titanium mesh usage. Okay, in Gucci et al., they proved there is no significant difference between the titanium mesh and the titanium reinforced PTFE in a vertical bone augmentation, and complication they are very the same. Because of dense and surface structure of the titanium mesh, there is less susceptibility to be adhered by bacteria. This, in accordance with the protective pseudoepithelium, these two factors work as this defense barrier for bacterial infection. Surgical management of the titanium mesh, particle of the graft material not only prevent formation of interstitial bone under a titanium mesh, but they have osteogenetic and osteoconductive properties in compare with the block bone graft. This is the advantage for the particle graft, which is supported by titanium mesh. Nowadays, the studies are focused on the different ratios, of autogenous bone and xenograft. Nowadays, the usual ratio is 50-50 or 30-70 in usual practice. You can see a mixture of xenograft and autograft, which is supported by titanium mesh. We can fill the space completely without any problem, and we can be certain that this will fill the defect correctly. And in other instances, the mixture of the graft material, which will be supported by the titanium mesh. Well, although histological, the study demonstrated that the preference of the increased ratio of the autogenous bone graft may increases the proportion of new bone formation. There's no statistical difference in the clinical outcome, and they are the same. There is no statistical difference to prove the autogenous bone play an essential role in the bone reconstruction. And similar and predictable result can be obtained in both autogenous bone or different xenograft bone material. using recombinant bone morphologic protein in the clinical research showed that autogenous bone graft, there's no significant difference in horizontal bone augmentation with or without using recombinant bone morphologic protein, although newly bone induced by recombinant bone morphological protein material or autogenous bone grafts. You can, any comments? Do you have any comments? What about covering material? A retrospective clinical cohort study found no statistical difference in the exposure rate of the GBR with titanium mesh with or without covering absorber collagen membrane, and even in some cases the exposure did occur. Dense fibrous tissue was still found under the titanium mesh. And we can consider that the covering absorber collagen membrane upon the titanium mesh cannot increase the mucosal healing speed. And it is difficult to reduce excessive soft tissue formation under the titanium mesh. All of this attempt done for decreasing the growth of the soft tissue underneath the titanium mesh, but almost always they occur. Her et al. Proposed that the hypothesis that once the blood clots stabilize in the bone augmentation area, the gingival connective tissue cell may be excluded like conventional GBR. Therefore, they want to emphasize this theory. Therefore, in GBR with titanium mesh, the mesh need to be firmly fixed and to prevent the macro motion. The macro motion prevents the fixation of the clot and prevent the common consequences which we need for fixation and to grow the material which is used for the graft. For single tooth replacement, there are two strategies: simultaneous and delayed implantation. In simultaneous implantation, we can fix the titanium with resorbable suture, but in the delayed implantation, the titanium mesh should be fixed by screwed on the specific basis. For a patient with bone augmentation for multiple tooth replacement, titanium screw can be fixed in between the implants area. Okay, as for a story, I can say the GBR at first introduced for maxillofacial bone reconstruction, and monarchs used titanium mesh for stabilize the autogenous bone graft for local alveolar ridge reconstruction. In some studies, they recommended to conduct titanium mesh bone augmentation for delayed implantation, and the results of Artsy et al. Study showed that no statistically significant difference between titanium mesh bone augmentation with staged implantation compared to the simultaneous implantation. An example for using titanium mesh for anterior part of the maxilla. In a simultaneously implantation using the graft by supporting, which support by the titanium mesh and fixed by filling a couple cover screw. One arts demonstrated that the GBR with titanium mesh in immediate implantation as an effective augmentation, but in this field, there is a lack of follow-up data to assess implant survival rate. But in Zhang study, which they used the mixture of allograft and autogenous bone graft, they used titanium mesh in immediate implantation. In this study, they have relatively successful regeneration in 1 year follow-up and showed that the implantation were successful. Again, in Gucci's study, placement on the implant in alveolar region simultaneously with using titanium mesh, in the defect with the bone defects almost 4 millimeter before augmentation, they could gain vertical bone almost 4.5 millimeter in height. And in Zhang et al. Study, L-shaped titanium mesh, as you could see in the two slides before, the mesh to conduct the GBR at the same time implantation, the patient with a small, medium, or alveolar bone defect requiring both horizontal and vertical bone augmentation. In a systematic review of simultaneous implantation after bone augmentation, demonstrated that the survival rate of implant placed in a native bone that one which place in immediately after bone grafting is similar. The survival rate of these two groups was similar. Here are some studies about the augmentation, the dentulous job during the 88 months follow-up. Newborn augmentation was done, and they had little resorption and did affect by function and didn't affect the function of the implant. And the procedure ends to good result. Sioka et al. Also used GBR with titanium machine, extensive alveolar defect, and the mean vertical bone height was almost 2 millimeter, was gained after recovery period of 6 to 8 months. The maximum mesh exposure was found in Sioka report, almost 66%. However, the exposure of titanium didn't lead to a significant impact on the result of bone reconstruction. A randomized clinical trial conducted by Rocuzzo showed that the onlay bone graft combined with GBR with titanium mesh achieved 13% of resorption, while the onlay bone graft alone had 34% in bone resorption. More bone resorption were found in the onlay bone graft alone, and the lower was found in the onlay bone graft combined with GBR with titanium mesh. In order to enhance the result and outcome, cover the hydroxyapatite particle with titanium mesh and reconstructed severely atrophic alveolar bone after the failure of onlay bone grafting. This was an attempt to restore the defect site. Chan conducted a GBR with titanium mesh in combination with the tendinic screw in order to gain vertical bone alveolar reconstruction, gained the average of 3.4 millimeter in bone height. He used the onlay xenograft in his study. About complication of titanium mesh, during the healing stage, the main complication is the titanium mesh exposure. The stiffness of titanium and the sharp edge, these are two main causes which ends to mucosal flaps dehiscence. The incidence of mesh exposure is most likely to be between 20 and 30%, and the high rate, as we mentioned previously, was 66% in one study. According to exposure type, we have early exposure and the late exposure. Early exposure occurred within the 4 weeks after bone augmentation and results in increase in fibrous tissue, decrease in bone formation, damage diffusion, residuals in the graft particle with surrounding bone. All of these are negative outcomes. And you can see another sample of exposure of the titanium mesh. Well, once exposure happened, the mesh should be removed as soon as possible, and consequent anti-infection therapy should be considered. The late exposure, which is occurred 4 weeks after the bone augmentation, may cause 15 to 25% of bone graphic resorption, and the exposed area may be caused to some significant bone volume loss. And after conducting the treatment and trimming the sharp edges of the regular exposed titanium mesh, the exposed area healed without removing. After trimming the sharp edges, the smooth surface of titanium and the protective effect of the pseudomembranous, these two factors acts as a barrier for microbial accumulation and subsequent infection. The soft layer of which we mentioned as pseudoperiosteum, protect the infection, protects from infection, provides adequate blood supply, nutrition, and exchanging the metabolic material, preventing the graft material from absorption. And when the titanium is early exposed, this role is preventing infection has not been achieved because the pseudoperiosteum has not been formed completely. And the area of exposure also has an impact on bone formation. Complex augmentation procedure are more likely to cause large area of the titanium mesh exposure. According to Fontana's study, we can briefly say about how we should do to prevent the exposure and to manage the situation. Before surgery, accurate evaluation of the patient's general health should be done. General and overall condition should be evaluated. Antibiotics should be considered if it is necessary. And the source of infection, any source of infection should be removed. During surgery, good flap design should be obtained to have a good blood supply and facilitate the flap closure. Titanium mesh should be immobilized tightly. Buccal periosteal in order to gain tension-free closure, and deep mattress and single interrupted suture are recommended. Application of custom-made mesh through the digital process can prevent complication due to avoidance of sharp edges, as I mentioned previously, and which caused by intraoperative bending. After surgery, as you know, systemic antibiotic may be necessary. Postoperative precaution, these are necessary. Nowadays research in bone augmentation about by helping the titanium mesh are focused on two things: digitalization and material modification of titanium mesh. You can see this in this picture. We can estimate the exact size for the graft material. Even we can imagine the exact size of the implant and the volume of material which will be need, and all, even the screw site for fixing the titanium mesh. All of these things can be estimated and can be calculated before surgery. And that's the outcome of the good planning of the mesh titanium. These topics are the disadvantages of the commercial titanium, such as difficulty in bending at the operating time, in imprecise shape by manual bending and contacting by gloves, and sharp edge which may be encountered at the operation time. Two kinds of procedure we have to make personalized titanium mesh for a patient. We can design the exact pattern of the titanium mesh and produce a final product by 3D printing or performing the titanium mesh preoperatively, on which on the analog on the alveolar analog which was printed by the information which is extracted from CBCT, CT, and oral scanning, and by the stereolithographic printing, and we can perform the titanium mesh over the model and preoperatively and use the titanium mesh at the operation time. Unit structure, pore size, and other and thickness in the 3D printing can be acquired according to the demand. But personalized titanium mesh by bending or by adapting on the model, the stereolithographic model, has lower technical sensitivity and better plasticity than the 3D printed titanium mesh. Okay, advantages of digitally process mesh is the opposite of the disadvantage of the commercial titanium, as I mentioned previously. Greatly shorten the operation time, suitable, adjusted, and fixed over the alveolar bone without adjustment, reduce the retention need, and really round, blunt edge formed by the 3D printing reduces the risk of the mucosal rupture. In the SUMIDA study, a comparison between personal titanium mesh, which was formed by SLM method, with a conventional titanium mesh. The time taken for surgery, the time taken for bone augmentation surgery with a custom-made titanium was shorter. The number of titanium screw was fewer, and no significant difference in the exposure rate between these two groups, although the personalized titanium mesh group was less likely to cause mesh exposure, 7.7%, and the other group, conventional titanium mesh group, exposure was 23%. But there's no there's no statistically significant in outcome. You can see the workflow, which was the other colleagues explained in the previous literature. Progress in the material modification. Some authors try to cover the calcium phosphorus coating in the GBR rat model in order to gain better result. No soft tissue innervation was found under titanium mesh in this study, and bone density in this group was significantly higher. as innovation, some researchers use strontium to promote osteoblasts and proliferation and differentiation of osteoblasts and inhibit osteoclast activities. That was combined with the calcium phosphorus coating. Strontium calcium phosphorus coating is more uniform and denser and enable a higher bone density in bone regeneration, improving osseointegration and preventing inflammation of a soft tissue, were the outcome of this study. The term of biological aging of the titanium mesh refers to covering the hydrocarbon molecule gradually over the titanium mesh, and this leads to loss of titanium hydrophilicity, damaging the conduction of osseointegration. These are all negative consequences about biological aging. What should we do? Any measurement which we can use is ultraviolet treatment. This treatment can change the negative charge to the positive charge at the surface of titanium, and the biologic capability of titanium enhanced, and the adhesion and retention of osteoblasts on the titanium increases, and considered a measure for solve the biological aging problem. In animal study, attracts more blood vessel to the bone defect area than untreated titanium, and the super hydrophilic surface is deemed more conducive to migration of osteoblasts. What should we do if the contact with glass happens? Cause biological contamination of the titanium mesh and resulting in a decrease in biological activity, although photofunctionalization cannot wholly remove the impurity, but it can remove the carbon and some other impurities, restore the biological activity of titanium mesh, and enhance surface adhesion of osteoblasts. Due to simple procedure of photofunctionalization technology, there's we need more attempt to gain more data about this clinical examination by using photofunctionalization. I have a special thanks to my dear colleagues, dear friend, Dr. Shirzadeh, and the organizers of this program. And thank you very much for your attention.
Thank you so much, Dr. Jabbari, for being with us, for accepting our invitation. It was quite a comprehensive gathering of the data.
Thank you very much. You're welcome.
And now, let's see if there is any question. I think that, is there any question? Anybody, any question? I can't see. It seems that there is no question. Dr. Jabbari, again, thank you so much for being with us. Like I said before, the lectures in this program all were very great and very, for me, they were very informative. And again, I ask all the lecturers one by one for being with us and accepting our invitation. Thank you so much, Dr. Jabbari.
Thank you very much. And thank you, my dear colleagues, Dr. Shirzadeh.
Yeah, Dr. Shirzadeh, thank you so much. I can see you over there.
Thank you so much.
Thank you so much
for our invitation in this program. I'm so honored to be part of this program. Thanks a lot. And see you.
It's our honor to have you with us, to have both of you with us. And to providing all these data for the all who want to use individualized titanium mesh.
I'm honored
I
so
think-
much. I'm honored so much to have such scientific colleagues in the
Yeah, me
fellowship
too.
program.
And also, Dr. Jabbar, I think first of all, before designing the titanium mesh, the processes should be designed. Prosthetic first.
Sure, of
Yes,
course.
sure.
Yeah,
it's
you
one-
are prosthodontics.
Thank you very
Thank
much.
you so
You can
much.
say everything we want.
Thank you very much.
Thank you so much.
Thank you so much. And now it's time to thank our the Chancellor of Tehran University of Medical Sciences, also Vice Chancellor for Global Strategies and International Affairs, and the Après-Suez team for helping us to have this program. And the Dean of School of Dentistry, Dr. Musavi, and also Dr. Hashemi, Vice Dean of International Affairs, that always supported our program. And also our executive team in this office, Miss, I think it would be very better that we gather all again together. Miss Ahmadzadeh, Miss Muaddab, and Dr. Muaddab. Unfortunately, today we don't have Dr. Panahi. And a special thanks to Miss Sadeghi, that during these 3 days always supported us with the internet, this connection, and all things else. So let's again together with each other have a نه اونجا باباش داره اینجوری هم میشه. Everybody چون اون دفعه با هم دیگه داشتیم. Okay, so as you see, Miss Sadeghi sitting, Miss Ahmadzadeh with the mask, and Dr. Muaddab all helped me in these 3 days and shared my stresses with themselves. Everybody, thank you for joining us. Thank you for being with us all these 3 days. And now it's time to say goodbye to all of you. Goodbye. I wish you the best of health and luck.